We are live.
Good morning, everyone. I'm Ann Garst-Taylor. I am the Director of Community Engagement for AIM at Melanoma. And I'm going to have an opportunity to talk with you later on about our organization and our patient resources. But I do want to take just a minute to acknowledge the 20th anniversary of AIM at Melanoma, to explain our mission and our origins. Val Guild founded AIM at Melanoma 20 years ago in memory of her daughter, Charlie. When Charlie was diagnosed with melanoma, there was only one FDA-approved treatment for stage 4 melanoma cancer. And after she died, Val was determined that she would form an organization that could help find a cure for this disease, as well as support people who are living with melanoma. The reason that it's important to talk about our 20th anniversary at this particular symposium is because of the guidance and the support that Dr. Kirkwood and UPMC has offered to the Guild family and AIM at Melanoma for the past 2 decades. You can imagine that we've done a lot of reflecting over the last, since January, about what this year means for us, what we hope for the future. And I was talking with Sam Guild, who is Val's daughter and Charlie's sister, about what she's thinking this year. And she was sharing some things with me, and I was so touched by the things that she said that I wrote some of them down. And I have forewarned her. She is watching this from California. She's aware I'm going to do this. And anybody that knows Sam knows how uncomfortable this makes her. But I wanted to share some of the things that she's thinking. So here's what she says about the 20th year. She says that reflecting over the meaning of 20 years of fighting melanoma, she feels honored and grateful to Dr. Kirkwood because he was one of the people that her mother could always rely upon. He and others have helped her mother to grow AIM from a small nonprofit into an international organization. And today you're going to hear a lot about the tissue banks that AIM at Melanoma funds. We've collected over 200 frozen primary tissues, and we're now working on making them available to researchers in the near future, so that we can take the next step towards a cure. AIM at Melanoma lost our founder in 2020. And though Val did not live to see her life's work come to fruition, she would be grateful to know that Dr. Kirkwood and others are making sure that Val's dream did not die with her. So we're going to have a number of presentations today, and what we'll be talking about is what the landscape of research and treatment looks like in 2024. It's a time of tremendous hope. I know that you guys are going to have a lot of questions for our presenters today. We have people that are in the room with us. We're so grateful that you're here. If you have questions, Dr. Kirkwood is going to offer you the opportunity at the end of each talk, as well as each section, to ask questions to our presenters. If you are joining us via live stream today, we have hundreds of people that are joining us via Zoom and Facebook and Live. We invite you to ask questions as well. And what we want you to do, if you are on Zoom, if you look at the bottom of the screen, you will see a tab down there that says Q&A. If you'll put your questions in there, we'll make sure that they get to our presenters. And if you are on Facebook or YouTube, just put them in the comments and we will transfer them over. And so that is all for now. I thank you so much for your attention, and I will pass the baton to Dr. Kirkwood, and he will start our symposium.
Thank you, Anne, and thank you all of our supporters, because we have 8 dedicated industry supporters today that you see illustrated on the panel here. who've made an enormous impact. But what we're here for is for you, the patients and caregivers. What we're here for is the 30, 40 people in person, but for the hundreds online, for whom the progress in the last 15 years has been head-spinning. It's been absolutely incredible. Melanoma has paved the way, has broken the path forward ahead of all of the other solid tumors, what we used to call the whipping child of our field has become a poster child. What we used to call a rut has become a groove. And in the last 6 months, believe it or not, we've had 2 new approvals of therapies. We have our 8th approval for adjuvant therapy, October of last year, for anti-PD-1, one of our solidest of the immunotherapies, for the treatment of people who have deep primary melanoma, but not nodal disease at all, expanding the spectrum of what we had. In fact, only 3 weeks ago, we had the approval of the very first tumor-infiltrating lymphocyte therapy, something that's approved in second line for people who have failed the other effective immunotherapies. So for you, the patients, our message is that things are on a roll, they're continuing on a roll, and it's really for you that the data that we present today is most important, because it's not for fellows and residents and students from the medical school, but for you, the patients, that this information is the most relevant. When you think about our exponents, our people who can carry the message forward, it's you in the community who can actually make the world aware of what progress we have. So I think it's really something which Val Guild would have had great gratification from, to know that we have had a cornucopia of new therapies approved and available for patients with melanoma, but a disease which used to take the life of patients, as I summarized this in a journal article only 18 years ago, in months. Now, 6 years and counting, more than half of those patients are alive with these new therapies, the checkpoint blockade immunotherapies, the targeted therapies, and all of the things that you will hear about this morning. So I want to again thank AIM, thank our sponsors, thank all of you who have joined the symposium today, and our speakers. And with nothing more ado, we'll turn to Dominic DeSalle, who will lead off. Melissa Wilson, our lead PA, became ill and couldn't come in today, so we wish her well in speedy recovery. But Dominic will take the ball forward. And thank you, Dominic, for pinch hitting for Missy. The topic will be the management of side effects for BRAF inhibitors. And these are our targeted therapies, the first of which was approved in 2011, the most recent approved in 2018, and a major form of therapy. Thank you, Dominic.
Thank you, Dr. Kirkwood. All right, so as you mentioned, this presentation was put together by our lead PA, Melissa Wilson. Unfortunately, she wasn't able to make it today, so I'm gonna fill in today. I'm Dominic DeSalle, one of the physician assistants with the melanoma group. We're gonna talk about the side effects, management of BRAF and MEK inhibitors. So about half of patients with diagnosed with melanoma are positive for this BRAF mutation, and depending on your stage of melanoma, your provider may recommend treating you with one of these medications. We combine the BRAF with the MEK inhibitors to not only improve the effectiveness of the cancer treatment, but also to help reduce some of the side effects. So on the screen are some of the medications we use to treat this, the more common being the ones towards the right side, the dabrafenib, trametinib, and the BRAF-TOVI, MEK-TOVI. So these next couple slides are talking about the side effects of the medications. This one specifically, just the BRAF inhibitors. So with these, we can see a rash that's more hive-like or macular, meaning a flat rash. Can cause hair loss. Fever is especially noted with the Tafinlar. Sometimes we can see GI upset, such as nausea, vomiting, and diarrhea, as well as headache, elevation in the liver function tests, which would be affecting the liver, joint and muscle pains, as well as dry skin and callus formations. These will be the side effects from the MEK inhibitors specifically. For this, we can see a rash that's more like acne-like. This will be raised. Later on in the presentation, there'll be pictures showing you guys about these, but it can also cause some cardiac complications such as weakness, dizziness, and edema in the hands and feet, as well as some ocular sensitivities like light sensitivity, blurred vision, double vision, some lung manifestations such as pneumonitis, which would present as shortness of breath or coughing, as well as some fluctuations in the blood pressure. Continuing on here, fever, as I mentioned before, is one of the most notable side effects from the BRAF-MEK combination. A lot of times, management of this entails just holding the pills for a moment in time. Like I mentioned before, this is particularly seen with the Tafinlar. The point, I guess, of this presentation is for any patients listening to this, if you experience any of these symptoms, it's important to call your provider's office for them to kind of direct you on the best management. Like I said, sometimes just best management for this medication and the fever for this is to just hold the pills, and then your provider will instruct you to resume them. So that's kind of that protocol for managing the fever. Sometimes if it's unsuccessful with just holding your pills, your provider may instruct you to decrease your dose of your medication. And as I mentioned before, sometimes fatigue, weakness, and arthralgias are other side effects. So some of the things you can do for the fever besides just holding the pills is to increase your fluid intake. You could also, if needed, start some IV fluids, some conservative measures such as taking Tylenol and ibuprofen, cold compresses, tepid baths, and occasionally we can use low doses of steroids. Some dermatologic manifestations of taking the pills is it kind of puts you at an increased risk of developing new cancerous or precancerous skin lesions such as squamous cell carcinoma, or rarely melanomas and other kind of precancerous lesions as well. This little asterisk at the bottom mentions that these are more common when these medications are taken separate, but when they're taken together, it helps kind of reduce that risk. So just an example of the rashes I was talking about from the BRAF and the MEK inhibitors. So that macular papular rash on the left side of the screen is more common from the BRAF inhibitor, whereas the acneiform rash is that more raised kind of punctate rash on the right is seen more from the MEK inhibitors. Continuing on, we can also see photosensitivity from taking these pills. A lot of our patients who are being treated on these medications are also undergoing radiation therapy. So it's important for us to instruct these patients to hold their medication while they're undergoing that therapy because it can increase your risk for developing burns from radiation. And on the right side of that screen is that keratoderma, which is some thickening that can be seen on the palms of the hands or the soles of the feet. Sometimes in mild cases, just moisturizer can help. Other times we have to send patients to podiatry or a dermatologist to help this. And I mentioned before about some cardiovascular toxicities that can be seen. So cardiomyopathy and QTC prolongation or other complications from these medications. But we try to be preventative about picking up on these issues. So most of the time or all the time, patients are started on these medications. We'll obtain a baseline echocardiogram of the heart to assess the ventricular ejection fraction as well as an EKG to check your heart rhythm to make sure that QT is in the normal range. It's important to note too, other medications that patients are taking that could also complicate any cardiovascular toxicities too, such as antidepressants, antibiotics, antipsychotics, and antiarrhythmics. We can see some GI upset as well, such as diarrhea, and nausea, vomiting, as well as some hepatotoxicity or liver toxicity. Sometimes the diarrhea can be managed. It's not managed by just holding the pills. We can try Imodium over the counter and continue the medication. If the diarrhea is more severe, we could hold the drug. And then if it's not stopping after discontinuing the drug, we can always reduce the dose too. And the hepatic toxicity is managed usually at the follow-up appointments by checking routine lab work to make sure those liver enzymes are within normal range. It's a more rare side effect, but we can also see ocular toxicities, such as uveitis, which is just irritation in the eye, some dry eye, retinopathies, and retinal vein occlusions. For these patients, it's important to send to an eye doctor specifically to help evaluate these issues. And that's kind of the end of the presentation here. So in conclusion, we use BRAF MEK inhibitors to treat melanoma. It's important to recognize the side effects of these medications. If you take home anything from this presentation, it's the importance of just calling your provider with anything you're experiencing, so that we can direct you the best way to manage these side effects. Any questions?
I have one from the internet.
Yeah.
We have a viewer asking, what exactly does it mean to be BRAF positive? And does it mean that you are more likely to respond to treatment?
Yeah, that's a good question. So for certain patients, we will obtain BRAF testing for, and it's just kind of a weakness that's found in your tumor. Then we can use those BRAF inhibitors to help target that.
Yeah, for the questioner, there are ARAF and BRAF and CRAF mutations, but BRAF is seen in 40 to 50% of melanomas. So it is, if you will, an engine that drives the tumor, and these BRAF inhibitors are like monkey wrenches designed to stop the engine of the tumor. The MEK inhibitors, which are given with the BRAF inhibitors, as Dominic mentioned, mitigate, lower the toxicities of the BRAF inhibitors. Think of them as a specific monkey wrench to interfere with the differential of the car called melanoma. And the two of them together are highly effective in the treatment of advanced disease. They're one of the arms of the adjuvant treatment after surgery that prevents relapse in more than half of patients treated if they have the BRAF mutation in the tumor. And so the bottom line is that doing BRAF mutation testing is incumbent upon us at the initial step of pathologic assessment for every patient, so that we know whether we have this option or not. To answer the question that might come from the same questioner again, to do the BRAF inhibitors, BRAF MEK inhibitors in patients who do not have a mutation actually may be adverse. So we need to know the mutation status. We therefore test it with the pathologists at the initial tissue harvest from every patient who has lymph node disease. And now we're also thinking about doing it earlier to know if that option exists for treatment. Thank you so much, Dominic. So as Dominic mentioned, our skin is our largest organ, and the skin is the target of the largest number of complications from BRAF MEK inhibitors, also the target of the complications that we see the most frequently with the immunotherapies that you'll hear about later. And so Darcy, who's been a dedicated allied health professional in the treatment area that all of our patients have gotten to meet there, we'll talk about preventative skincare, because many of these potential complications can be mitigated before they happen. Darcy, welcome.
Thank you, Dr. Kirkwood. Welcome, everyone. I'm Darcy. I'm one of the PAs that works in the research side on the Melanoma Center. So we might not have met all of you, but I've been working with Dr. Kirkwood and Melissa and the melanoma team for 9 years now. So it's been, a good position. I really enjoy taking care of all the patients that we have. It's definitely very fulfilling for me. So today we're going to talk about preventative skincare. So we like to talk about how to, like Dr. Kirkwood said, manage these symptoms before they happen. So we're going to talk about a couple different things today, just the anatomy of the skin, and then I'm going to focus on moisturizers and sun protection. So why is this important? Our skin, as Dr. Kirkwood said, is our body's largest organ, and it is our defense system from the outside environment. So it's going to protect us from bacteria and viruses, UV light, dehydration, mechanical damage, like getting a cut or things like that. Our skin has our nerve endings that can alert us to temperature changes and pain, and then obviously it helps with temperature regulation. So really quickly, just to go over some skin anatomy, we have the top epidermis, that is the top layer, and then in the dermis, we have our nerves, our sweat glands, the hair bulbs, and then below that, the veins and the arteries, and then the sub-Q layer, the fat underneath there. So the skin barrier is made up of dead skin cells, proteins, fats, lipids. I want to focus on the ceramide. So those are the lipids. They make up about 50% of the epidermis. And we want to think about those as the glue that holds our skin cells together to form that healthy skin barrier. So over time, as we age or even get exposed to different treatments, our skin can become thinner, less elastic, and that leads to increased moisture loss. So you may see in different lotions and things, a lot of companies are including ceramides in their lotions. I feel like that's gotten a lot more popular over the last couple years. So that's why I wanted to talk about those. So they help us replenish that skin barrier. So typically what I recommend for a moisturizer to my patients is moisturizing at least once a day. Doing that right after you get out of the shower to kind of trap that moisture in can be beneficial. Ideally twice a day, especially if you're on treatment. I do definitely see a lot of patients complaining of dry skin when they're on treatment. Some areas, especially the hands in the winter, can require more frequent application. And then this is going to be if you are having a rash or something that requires a steroid cream. The moisturizers are going to be in addition to that. So it's really important to keep that skin barrier intact in addition to our steroid creams, because those can cause skin thinning as well. So what are we going to look for when we're looking for lotions? Fragrance and dye free. We don't want to add anything that's going to cause an allergy, or an irritation. Alcohol free, because alcohol is drying. Again, that's hard in the winter, especially if you're in healthcare and you're using hand sanitizer and things like that, which is why the hands often need more application. Brands that Melissa and I have recommended to patients: CeraVe, Eucerin, Cetaphil, Gold Bond Ultra Healing, and then Aquaphor ointment can be beneficial as well if you have a really dry area. I know when my kids were little, that was something that I really used a lot for them and still do in the winter. On this picture here, kind of illustrates a little bit about how the ceramides work. So the ceramides are that thick layer, and then the corneocytes, those are the dry or the dead skin cells that kind of come to the surface. So you can see the difference between the healthy skin and the dry skin. The dry skin has less ceramides in there, and so it's allowing the sun and different issues, different bacteria, things like that, to come into the skin and cause problems. Moving on to ultraviolet light, which is another big one that I know we've talked about in this meeting before. UV radiation is invisible radiation from the sun that damages the DNA. I think most people know that. So the UVA reaches the Earth's surface. It can go into the skin and damage connective tissue of the skin's DNA. UVB helps produce vitamin D in the skin and doesn't go as far into the skin, but can still cause sunburn and damage. And then UVC rays are absorbed by the ozone layer. So why is sun protection important? Just a couple facts here. Skin cancer is the most common form of cancer in the US. Nearly 20 Americans die from melanoma. Sorry, skin cancer melanoma is the most common form of skin cancer. Sorry, that should not say that. Nearly 20 Americans die from melanoma, the most dangerous type of skin cancer every day. The number one cause of melanoma is exposure to natural and artificial UV light. So research has shown that regular use of sunscreen in young adults is associated with a reduced risk of melanoma. So with sun protection, the two big classes that we talked about are mineral versus chemical sunscreens. Mineral or physical is illustrated in this picture here. It is going to sit on top of your skin and create a barrier, a reflective barrier. So the sun's UV rays just bounce off. In chemical sunscreens, the UV rays, the sunscreen is absorbed into your skin to form a chemical layer, and that chemical layer absorbs the UV light and scatters it and releases it as heat. So you want to think of the mineral sunscreen as a shield. Like I said, it sits on top of the skin, and main ingredients of those are going to be zinc oxide and titanium dioxide, sometimes a combination of both. This offers immediate protection, which can be beneficial. I know a lot of people don't like to wait for their sunscreen to work. So all of these sunscreens should be broad spectrum, water resistant, and SPF 30 or higher. Chemical sunscreens, again, absorb the sun's rays. So lots of big words for the ingredients here: oxybenzone, avobenzone, octitolate, octocrylene, homosalate, and octinoxate. So those are all these crazy big words that people are like, what does this mean? So these are the chemical sunscreens. You do need 30 minutes prior to sun exposure for these to work. And just with the minerals, they should be broad spectrum, water resistant, and SPF 30 or higher. So here are my take home pieces for this. So I think the biggest issue with sunscreen is that people don't reapply it often enough. So you want to be really mindful of that. Reapplying every 2 hours when you're in the sun. And if you're swimming or sweating, even with these water resistant ones, you're going to need to reapply more often than that. Really important for sunscreen to check expiration dates. I do not recommend using any sunscreen that is expired. For the facial applications, the sticks can be easier to use. I know that's what I use for my kids in the summertime. And then probably the second biggest issue is people aren't using enough sunscreen. So you need 1 to 1.5 ounces to cover the body. And then if you're applying on your face, you want to do 2 finger lengths. So apply 2 finger lengths, and that should be rubbed in on the face and the neck. Sunscreen sprays, I know everybody likes those for the convenience. Those can be a little challenging. You can't tell how much you've used. The wind can take away some of it. But I know people like those, and sometimes that's the only option. So some sunscreen is better than no sunscreen. So if you're using a spray, you want to spray until your skin is glistening, and you want to rub it in to ensure even coverage. If you have to use it on the face, you want to put it in your hand first and then rub it on your face. So to make sure you're not getting it in your eyes or inhaling any of those fumes. So other things that we can use for sun protection is going to be UPF clothing. So that stands for ultraviolet protection factor. If you get one that's UPF 50, it's going to block 98% of the sun's rays. And this is both UVA and UVB. You can find this in swimsuits, rash guards, and this has come a long way over the past 9 years. They make this for dresses, hiking shirts and pants. Any activity that you're going to do in the sun really is going to have something with clothing with UPF factor in it. And this is important because you don't have to remember to reapply it. That coverage is going to be there as long as the quality of the material isn't compromised. Hats, super important. We want a wide brim, 3 inches around, and that's going to protect not only the top of your head, ears, and back of the neck. Those are places that I often see sunburn in patients. Again, same with the clothing. Those need to be tightly woven materials. So if you're buying a straw hat and you hold it up and you can see light coming through it, that's not going to provide you with enough protection. Sunglasses are also super important. Those should be 100% UV protection. You want to wear those anytime you're outside, even when it's not sunny, even when it's cloudy. That is still something that's important for us to think about. References, and then here's a picture of my kids with their sun protection. So these are a little older. They're older now, but back you see at the beach, both wearing their hats and their rash guards. And then the slide is at their summer camp last year, both wearing their rash guards. And that's it for me. Any questions?
Darcy, can I ask you a question?
Of course.
So, as you know, melanoma in the man is most common on the back, and I hear every single patient, every single week saying, but I wear a shirt. How do you think we can overcome this misconception? They all think they're protected.
Right. So, you know, a regular cotton shirt that probably most men are wearing isn't going to provide sun protection. So I think we as providers probably need to do a better job of explaining how the difference between just regular cotton clothing and clothing with BPF factor in it. So tell them if you're holding it up to the light and you can see through it, just like I said with the hat, it's not going to provide enough protection. I think I hear that a lot with patients, even saying like, oh, I was in the shade from a tree, but you know, the tree moves, the sun's moving, you're still getting exposed to that. So explaining that, you know, in your visit, especially patients that are on BRAF MEK inhibitors or have really a lot of photosensitivity, and the difference between regular clothing and those UPF clothing is going to make a huge difference. Just reminding them of that.
Yeah, the question from Dr. Major is interesting because it isn't chronic low-level sun exposure. It's not the farmers and the fishermen who get melanoma. It's intermittent blitzes of sun. You know, those of us who spend our lives inside like this and then go out. And so it isn't that they wore a t-shirt most of the time. It's the intermittent no t-shirt and burn that gives men, mostly over 50, like sadly some of us are, who basically have a rising incidence of melanoma. Darcy mentioned that we're the fifth, melanoma is the fifth commonest cancer of all solid tumors now, but with the trajectory that we've seen over the past decade, it is anticipated by 2040, which is only 16 years away, it could be second of all cancers. So our once thought to be rare cancer ain't rare at all, and it's getting more common, and it's intermittent sun exposure, you know, the blitz of sun they got when they didn't put the shirt on or didn't wear the sunscreens. But that was lovely, Darcy. Thank you. Good. So our next talk is from a hidden hero of our program. And all of you know from what Anne presented at the outset, that primary melanoma tissue banking is part of the mission that Val Gild, Susan Steele, others really embraced 15 years ago when we began to try to drum up support for this. But tissue is the issue, because if we don't have the tissue, we can't possibly understand the mechanisms that underlie all of these phenomena that you've heard about from Darcy, and you'll hear about ever more from Jana and Diwakar and Brittany going forward. So tissue isn't quite as simple as it would sound, because it's very hard to get these samples. It's hard to get consent from people in advance to be able to collect the samples. And we have a huge resource here in our data acquisition and data entry team, led by Mary Horak, who's actually been a part of the melanoma program back 25 years ago, I think.
Not quite.
Not quite, almost 20. But basically, we'll speak to you today about the nuances, the subtleties, the challenges of tissue banking, which is what allows us to understand how the things that work, why the things that don't work, and the ways that we can abrogate resistance to the treatment failures that we've actually encountered. Mary, thank you for coming.
Good morning, everyone. Thank you. Thank you, Dr. Kirkwood. So I work in our clinical research services department. We are the department that provides the infrastructure here at Hillman to conduct all of our clinical research trials. And my goal is to talk to you about how we use
tissue and how that translates from the benchtop research lab into new treatments for our patients. So we'll start with the basics. What is tissue? So a tissue is a layer of cells or a group of cells working together to perform a function. So Darcy just explained to us the skin being the largest organ. So the skin functions to protect us. Our blood functions to send oxygen through the body. So that's what we're talking about when we say tissue. So in research, we're referring to more than just tumor tissues. We are referring to that, yes, but then also things such as blood, urine, stool, other organ tissue, normal organ tissue. So normal tissue is just as important to look at to see what it's doing versus our tumor tissue. And these samples are often referred to as biospecimens or correlative samples. So we use tissue clinically to make a diagnosis for cancer. So we want to know what kind of cancer you have so we can treat it appropriately and give you the best treatment option for that cancer. And we use tissues to find ways to prevent, diagnose, and treat cancer. And this tissue research takes a long time. We need a lot of samples from a lot of different patients. So we need to involve a lot of institutions outside of ourselves to do this work. And it takes a long time for this research for those results to be known, to really know what we're seeing, what trends we're seeing. So the tissue for future use is often stored in a tissue bank. And a tissue bank is a facility that organizes these tissues. They annotate them, they collect them, they store them, and distribute that to researchers so that they can do basic and translational science. So again, taking what we learn from tissue, translating that to our patients. And by studying these tissues in a laboratory, we can discover different biomarkers, molecules to learn how cells work and how they might respond to treatment. And our basic science also begins with this tissue, this research, which leads to these new treatments. So our laboratory technicians are really the ones who process these tissue samples, make sure they are stored in a way that's viable. So when our researchers want to actually analyze these tissues to answer their questions, that tissue is adequate. So here at Hillman, we are very fortunate to have a few different melanoma tissue banks. Two really important ones are our 96099 tissue bank, which has been collecting samples at our UPMC Hillman location since 1997. This predates some of the age of some of our staff in our department now, so it's been a long time we've been collecting these samples. And then with 96099, we typically collect blood and tumor samples, but we can also collect other types of tissues as well. And then 16055 is a tissue bank open here, but also open across the United States with several different sites, as well as in Australia. And 16055 is really important because this is supported through AIM at Melanoma. So we really appreciate their support. This is the tissue bank that Anne was referring to this morning when she opened. So with this tissue, we are able to collectively gather samples from patients across the United States, across the world, really, to use this information in projects to learn more about melanoma. So how do we use this tissue? Again, we're really trying to determine how well patients will respond to treatments and how the treatments really work. And we can develop a theory and then use this tissue to test that theory to see if we are onto something. And research with molecular mutations really has resulted in treatments that we can target towards those mutations to give you that personalized medicine. So Dominic started this morning talking about BRAF. So BRAF is a common melanoma mutation, as well as NRAS, c-KIT. So again, we target these to give you the best treatment for your cancer. So we collect this tissue. What do we do with it? Why do we analyze it? One way is to determine a response to treatment. So these slides are examples of what we call H&E staining. And on the far left, we can see normal tissue. So we see what tissue should look like. In the middle and the right shows a pathological non-response and a pathologic complete response. So this is work from Dr. Najjar, and with a pathological non-response, this tumor did not respond to tissue to a treatment, whereas the pathological complete response, that tumor did respond to a treatment. So this gives us a lot of information, but it doesn't give us the whole picture. So we don't know why the non-responder didn't respond, and we don't know why necessarily the complete response, what killed those cancer cells. So we have to delve a little bit deeper and look at more of the tissue to understand really what's going on. And with that, we can analyze tissue to assess the tumor microenvironment. And the tumor microenvironment is the cells and the tissue surrounding the tumor, which can work to help feed that tumor. The tumor can affect the microenvironment, but then the microenvironment can also affect the tumor. And we can determine response based on the microenvironment as well. So there's many different ways we can look at this microenvironment. Each technique gives you a different perspective and a different way to look at that. But we like to look at it collectively as a whole, because if we're looking at just, for example, CD8 here, you're not getting that big picture. So this is called fluorescent microscopy. And when we combine it together, we see that big picture, and we can see something like the blue cells are the active tumor, and we know what those tumors are doing. To kind of further look at that microenvironment, we can also look at biomarkers. So when we're looking at biomarkers collectively, and we can see trends over several samples, we know we can target that to try to develop therapies to treat those tumor types and develop those personalized therapies. So here at Hillman, going back to the 96099 tissue bank, we have several projects ongoing at any time, but two I wanted to highlight is a project with patients with multiple melanoma diagnoses. So the goal of this is to look at those patients to see if there is some sort of inherited genetic risk factor that's causing those patients to develop another melanoma. And this is a partnership between us and Cleveland Clinic. So again, using another center so we can have a wider assortment of samples and a larger patient population, hopefully get this research done a little quicker. The second project is looking at genetic mutations in cutaneous melanoma patients and looking at the implications for recurrence. So these are patients who have not recurred, and we're trying to investigate genetic mutations to see what might predict potentially which patients will recur and at what time frame. So will these patients recur in 2 years, in 5 years, greater than 10 years? As an example of a project that's been completed, we had some researchers looking at acromelanoma specifically because we know acromelanoma doesn't respond in the same way as the other cutaneous melanomas when we give them checkpoint inhibitor treatment. So in this, they identified a unique set of pathways associated with that resistance. And from that information, again, we can develop treatments to focus on that pathway to treat these patients. So this is an example in the images at the bottom. We have some H&E staining on the top. So you see the dark purple is tumor tissue. And then again, that fluorescent microscopy where we can see the different tumors, like the different cells lighting up based on the imaging. So this tissue research, again, really drives and lays the foundation for developing clinical trials where we're actually treating patients to see if treatments are effective. So clinical trials are written by our researchers along with biostatisticians who help ensure that we write these protocols in a way that we can actually measure the results and determine that they actually mean something. It's not just random chance, but there's a statistical component to it that we know that this actually means something. So we use something called objectives and endpoints to kind of frame the research question so we know what kind of data we need to collect to answer that. So often for clinical trials, the endpoints are safety and effective. So not all trials have these endpoints, but these are common ones. So safety, we're looking at adverse events. So what kind of side effects are our patients experiencing? Efficacy is the disease response. So how are our patients' tumors responding to these treatments? Are they getting better? Are they staying the same? Are they getting worse? All of that's important information for us to learn. So when we're collecting data, whether we're looking at tissue banking trials or clinical trials for treatment, we have to collect the clinical characteristics of our patients. So we need to know their information such as gender, racial, ethnicity group, their age, their prior treatments, their diagnosis date, what type of melanoma they have, because we have to correlate this with our results so that we know that how everything kind of comes together so we know which treatments will benefit which patients the most. So one of the things that's really important is prior cancer treatments, because we need to know if a patient had a prior treatment, maybe that prior treatment is causing this new treatment to them to respond better. So when we're looking specifically at tissue banks, we need to know what tissue is there, what samples do we have, so that when a researcher has an idea for a project, we know that these samples are available to conduct that research. So the most important thing is the sample identification. Where is it? What is it? Is it blood? Is it tissue? Is it tumor tissue? Is it plasma cells? All of that kind of thing. When it was collected, so how old it is, when it correlated to the patient's diagnosis. So all of that's really important for us when we're building these tissue banks. Keith's computer is going to restart in 9 minutes. I don't know if that matters. Sure.
You've got lots of time.
Okay.
Will research from the tissue bank, also be
So that's some of the research we're doing. So based on what, okay, so more to come, but yes, it can. That's some of what we're doing. Okay, so we need to know what we have. Also for our samples, if it is a tumor tissue, we need to know those pathologic details. So is it cutaneous melanoma? What kind specifically? Is it acral melanoma? Is it ocular melanoma, mucosal? How thick it was? All of those kind of characteristics we need to know and annotate. So when, again, a researcher wants to conduct a study, they know exactly what they're getting. So if we go back to that acral study that was conducted here, when they were ready to perform that study, the tissue bank had to provide them acral melanoma samples. So how it comes together. For shifting and looking at clinical trials, again, when we're looking at things such as safety or efficacy, when we're looking at safety, we're looking at those side effects. So like Dominic talked about with the BRAF inhibitors, what kind of side effects do patients have? So we record every side effect a patient complains of because we need to know, is that really related to the treatment or is it from some other cause? So we have a standard system where we grade these based on severity. And we have a tool that we use that makes sure that we are using the same methodology across all patients. And then our investigators, so our research trained physicians or physician assistants, are looking at these side effects and determining, are they related to the treatment or some other cause? So if the patient has weight loss, did they lose weight because they were so nauseous they couldn't eat, or did they lose weight because they went on a diet? So this is the kind of information that we're teasing out to determine the safety of our drugs. When we're looking at efficacy and how the disease is responding, we look at baseline prior to the treatment and then the subsequent scans at whatever cadence is required for that trial. So here we have a baseline scan on the left, which is a CT from before the treatment started. And then we have a CT 3 months into treatment, and we translate that information from the scans into a format that we can reproduce and we can analyze. So this is something we call in clinical research our tumor measurement form. And so on the left, you can see, hopefully if it's not too small, that this patient's tumor burden at baseline was 3.37 centimeters. And then after 3 months of treatment, we rescan them and their disease reduced down to 2.3 centimeters. So that's a 32% reduction. So that's really good. We really like to see that. And then we categorize that in a response. In this case, it's called partial response. So we have these, again, different criteria there. We can categorize these responses using the same methodology across all patients, whether it's here or in Cleveland or California, we all are doing it the same way. So our responses are categorized in complete response, so all that disease has gone away. Partial response, where the disease has reduced by more than 30%. We have progression, where the disease has increased by 20% from its smallest volume. Or if it doesn't meet any of those, it's called stable disease. And stable disease is still a good thing. So that's how we're collecting this data. So once we have all of this, we have to organize it in a way that we know what we have and we can actually analyze it. So we enter it into a database. Here, all of our data is manually entered by someone. And there's different databases, they capture the same type of information, they're set up the same similar ways. Medidata Rave is one we use commonly, Inform is one, and then RedCap is what this screenshot is. And that's the database we use here at UPMC for our trials written by our physicians. And the information we're collecting is that adverse events, the tumor assessments, but also those clinical characteristics. So the patient's diagnosis states, their prior treatments, all of that information we're entering into the database. So while the main objective of most of these trials are commonly safety and efficacy, we are looking at tissue a lot of times in secondary objectives. So these are used to determine how the treatment is changing the tumor, or how the body is reacting to it, or how it's changing the body's immune response. So the goal of all of this tissue research is to forward science and develop future treatments and treatments that actually work better. So how this all comes together is all the data that we collect is pulled together. It's any, whether it's clinical trial or for tissue banking, we correlate those clinical, the clinical data with those results. We send it to our biostatisticians. They're the ones who conduct the analysis, and they will group patients differently based on, again, the objectives. So they're looking at gender, age, prior treatments. So do women respond differently than men? Does an older population respond differently than a younger population? And then also tissue results. So grouping them by molecular diagnosis or molecular mutation. So the BRAF patients versus non-BRAF mutated patients. So all of this it takes a long time to collect all the data for clinical trials. And once the biostatistician reviews this, completes the report along with the investigators, we make that determination of how well the treatment actually worked. So with that, we can use that information to design new trials to kind of change the course of what we want to do with that treatment agent, or we can submit it to the FDA for approval. So the FDA makes sure that the data is clean, that it is accurate, and that it is a safe and effective treatment. So they thoroughly review all of this information. And then ultimately, we get drug approval. So the work that we do here in Hillman absolutely and directly contributes to the new treatments for our patients. So as Dr. Kirkwood mentioned, when we began, we had 2 recent approvals, one just in February for the T-cell therapy, which was under a clinical trial 16126. And then our clinical trial 19105 is the one from October where Nivo was approved for our adjuvant patients for stage 2B and C melanoma. So hopefully I've convinced you why it is so important to give us your tissue. Contributing to your tissue will help move science, help advance science. You can help us find a cure, and you can take an active role in your healthcare. You can learn more about your melanoma and the treatment by giving us tissue, and your participation is always voluntary. So whatever tissue patients are willing to give us, we are so gracious for whatever they are. And it's always, always, always voluntary. So a huge thank you to all of our patients who have given us their tissue samples and who participate in our clinical trials. And without you, we would not be here. A couple of references.
How can patients donate?
So for donating tissue, we would consent the patient. So every clinical trial, whether it's for tissue or a treatment, we make sure patients understand what they're signing up for. So what we're taking, so are we taking a tumor sample? Are we taking 14 tubes of blood? What we plan on doing with that. So once we obtain your consent, we will draw the samples. If you have a surgery, the tissue will go to pathology for normal diagnosis, and then anything extra we might take for research. So if you come to one of our clinics, you've probably been asked to participate in 9699. But yes, it would be a consent process, and then the tissue is collected for the treatment or per the protocol.
So what Mary has just presented is really, as I opened to say, unsung hero effort. Basically, we do dozens and dozens of new trials. These trials lead to new approvals, but we're able to take with the tissue banking protocol, the 8,000 patients who have donated blood, allowed us to take tissues that were not required and analyze those and do dozens of other trials retrospectively in the tissue bank. And without the information that Mary puts on the samples, the annotation of the samples, these samples would be useless. Without your support and the continuing support of each of the faculty who talk to you in the clinics to explain why we want to have blood drawn at the start of your story. Every single patient I saw new last Wednesday, we asked, would they be willing to donate a sample? But this is the reason. And this, in one sense, is the reason we have a SPORE grant, a specialized program of research excellence. One of the key requisites for that is having a tissue bank that people can ask questions retrospectively about the disease or prospectively. And so this tissue bank is really something that
Sorry, guys, we lost the feed, but we're one of the technicians over there is getting everything set back up, and we'll get the feed right back in a few seconds.
And said, hooray, that must be you back on. Sidebars and comedy, you all probably don't know this, but in our clinics, we have pauses like this quite regularly when the whole system fails us and we have to wait to go out, have coffee and come back. But thank you for your patience, and we'll continue on. Thank you, Yana.
Hi, everybody. Thank you so much to all of you for being here on a Saturday and those of you who are online. I also just wanted to take a second to say that I had the great pleasure and privilege of knowing Val Guild very well. And thanks to John, I was invited within a day of having become an attending to go to this Women in Melanoma Symposium, which is where all of us female academic oncologists, dermatologists, surgeons, very focused in melanoma, meet up once a year. And actually this will be I believe my 8th year going. It's really one of the best meetings of the year. We get together and we talk about patient-facing issues. So I am one of the melanoma medical oncologists here. And today we'll be talking about whether or not we can predict who will respond to immunotherapy. That's really the burning question, I think. It's one of the many burning questions that keeps, certainly I know I speak for Dr. Kirkwood and my partners and I, that keeps us up at night. So historically speaking, of course, cancer is not a new problem. This is not a new plight. But if you were somebody living in 1450, your average life expectancy was probably to about 28. And so actually you'd be geriatric at 28. And we are now living longer and longer. And so this is why we are seeing cancer more and more. In fact, the median age of, or I should say rather, the average age of melanoma diagnosis in the US is 65. So over half of patients are over 65 when they're diagnosed. So I think that really drives home what I was referencing. I really like history, so I look at everything from a historical perspective, but there are mentions of breast cancer tumors being cut out. Of course, they didn't have the language for this. As far back as 1600 BC in hieroglyphs. And so what we have done, now it seems, medieval, even though this is what we're doing until quite recently, you'd cut it out, you'd give chemotherapy, which acts functionally as a nuke, killing good cells, bad cells, all cells. We then had the rise of radiotherapy, various chemotherapies, and we have become slowly, but also in a way very quickly, because we've picked up speed, much more sophisticated in how we care for our patients. The old paradigm was that you would directly target the tumor, cut it out, zap it with radiation, hit it with chemotherapy. The new paradigm is we're not really bothered, if you will, by the tumor. We're bothered by how can we switch on the patient's own immune system, because this is something that the gentleman in front of me referenced very correctly. Cancer in general and melanoma in particular, I think we could successfully argue is fundamentally a failure of the immune system. How did the cancer get to grow in the first place? How did it come to equilibrium with the immune system? And then how did it manage to escape and evade the immune system and spread to the brain, lung, liver, etc.? It's because the immune system did not see what was going on. And so what we all try to do is understand how we can overcome that. When I was training, when I was in medical school now 20 years ago, we would measure life expectancy for a patient with advanced melanoma in the order of months. It was a very depressing field. And this is why I have to really tip my hat to my mentor and now dear friend, Dr. Kirkwood, who stuck it out. I came into this really because I was interested in immunotherapy 10, 15 years ago. And so I've seen the sea change. But I'm standing on the shoulders, as are all of us, of people who stuck with it for decades and decades when we didn't know what was going to happen. There was, the idea of immunotherapy in melanoma. Now, as Dr. Kirkwood said, we really are leading the field. The first immunotherapy was approved in melanoma. First combination in melanoma, without exception, most recently Opdualag. That's the first time we're hitting a target called LAG3, approved in melanoma. First time we used immunotherapy in stage 3, melanoma. First time we used it in stage 2, melanoma. You see where this is going. But for a long time, that's really not how it was. And now, when we see a patient diagnosed with stage 4 melanoma, and we see at least 5, 6, 7 new patients a week, we can tell them that if we treat them with immunotherapy A plus B, their odds of being alive at 7.5 years now are 48%. That is astounding. And I don't think in my lifetime that'll ever get old, because I remember very clearly how it was before. The thing is that we have to be very careful not to say, oh, great, we think we're curing 48% of patients. The real question is, how are we failing the balance of 52%? Those who have not responded to therapy, that's what we're now focused on, which is to say we're not patting ourselves on the back, right? There's still a huge amount of work to be done, which is why we're all here. What we're really interested in understanding is why some patients respond to immunotherapy and others do not. And what I want to do here is really try and set the stage, because I don't want to get lost in the weeds of the jargon, but I want to make sure that what I'm saying makes sense. When I say, can we predict who's going to respond to treatment? What I'm really asking is, do we have a predictive biomarker? Biomarkers are basically different things: lab values, microscopic findings, imaging findings, proteins, anything you want can be a biomarker. A prognostic biomarker will tell us how the patient will do, irrespective of treatment. For example, we know that if a patient's melanoma goes to the brain, that's generally not a good thing, even though we have very good treatments now. A predictive biomarker predicts whether or not a patient will respond to therapy. So that's really a foundational concept for the rest of my talk, not to be gibberish. One of the talks that came in, one of the questions that came in very early this morning was, if a patient has a BRAF mutation, are they more likely to respond to therapy? The answer is a resounding yes. And I put this in here because I want to say that the BRAF mutation, which is found in about half, 40% to 50% of cutaneous melanoma patients, is actually a very robust and an excellent predictive biomarker. I can very confidently say that if a patient has a BRAF V600E or K mutation, they will respond to BRAF targeted therapy. So that's a good example. And there are multiple combinations of BRAF and MEK inhibitors, which I won't get into because that's not the scope of our discussion. But the point I want to make is that for BRAF mutant patients, we have a first-rate predictive biomarker. For immunotherapy, not so much. And that's what we're going to talk about today. Why is a predictive biomarker so important? This past week in my clinic alone, we probably had 7, 8, if not more, patients come in and start treatment. Some are starting for stage 2, some are starting for stage 3, some are starting for stage 4. And some are starting a new treatment for stage 4 that did not respond to the frontline treatment, the first thing that I thought was best for that patient. The problem is, if you're one of me or one of Dr. Kirkwood, we go in really not knowing, and I want to be clear, I'm speaking here about immunotherapy. We go in not knowing who's going to respond to treatment and who isn't. In a way, we are going blind. I know some patients are going to have an amazing response. And I know that for some patients, the treatment is not going to touch them. Who's who? I have no idea. And that's what we're trying to figure out. The reason it would be very important to have a predictive biomarker is that we can tell early on who is not going to benefit, and we can spare them toxicity. Immunotherapy, while generally well tolerated, certainly is not sugar water. And there are serious and rarely life-threatening toxicities associated with it. We would be able to spare patients whom we know have low likelihood of benefiting from treatment the toxicities, the adverse effects of immunotherapy. Never mind the strain on the healthcare system itself. And it would allow me as a physician to make a very informed decision up front and pivot to a different line of therapy. We know, for example, that regardless of, I'll rephrase, we know that patients who have a BRAF mutation do better if we start with immunotherapy. But maybe if I had a predictive biomarker and I knew that patient X was not going to benefit, I would ignore that data and I would start the patient on immunotherapy. Excuse me, on targeted therapy, on BRAF MEK inhibitors rather than immunotherapy. Now with the approval of the very first cell therapy in solid tumors, also in melanoma, might I add, I might choose to do that for a patient before putting them through the rigmarole of immunotherapy if I know it's not going to work. And yet, as of today, we do not yet have a predictive biomarker that is sufficiently robust to inform our decision-making. Now, to have a predictive biomarker, ideally, you would be meeting several criteria. You would have high accuracy. This is obviously very important because we're making huge decisions about patients' treatment on its basis. Minimally invasive. Obviously, we don't want to be biopsying a patient again and again and again in their tumor. If you are very fortunate, you would identify one in the peripheral blood, for example. Something that you can scale, a biomarker that is not just done at a center of excellence like this one, but something that can be done in the community. Something that somebody could do in North Dakota as well as they could do in Beijing. And highly reproducible, i.e. validated, something you can depend on. This is a very exhaustive review that we published recently in Nature, looking at all of the different biomarkers that have been evaluated in the context of immunotherapy in particular. And I really don't want to take us completely off track, but I wanted to say that even though these are not ready for prime time, in the sense that you will not see us using these to determine your treatment, typically in clinic, there are some that we are using very, very frequently. One is circulating tumor DNA. Certainly, I know in my clinic and Dr. Kirkwood's, because we overlap once a week, this is something we're sending all the time. We look at the levels of circulating tumor DNA to get a sense of, is it going up or down? And certainly I won't change therapy accordingly, but it gives me a very good sense of whether or not a patient may be responding. The way I put it to the patient is it's an additional data point. How you're doing your scan, how much of your DNA from the tumor is circulating in your bloodstream, all of this together helps me make the most informed decision I can. Something my lab is very interested in is immunohistochemistry and immunofluorescence, and I'll come to that very shortly. But there are a lot of different biomarker technologies under evaluation. So PD-1 is the receptor that sits on T cells, your immune cells, and it binds to PD-L1, which is expressed on tumor cells, such as melanoma. And for very obvious reasons, it's probably not a leap to imagine why in the beginning we all thought PD-L1 was going to be a gangbusters biomarker. We were absolutely wrong. This is a figure that you can see from the pivotal paper that led to the approval of nivolumab and ipilimumab. And the long and the short of it is you can see that whether or not a patient had PD-L1 did not definitively tell us whether or not they were going to benefit from treatment. You can have low PD-L1 in your tumor and have great benefit. You can have low PD-L1 in your tumor and have no benefit. And so it doesn't steer us, which frankly surprised me 10 years ago now. And this is also true of every other one, by the way. This is true of CTLA-4. This is true of LAG-3, most recently with the approval of relatlimab, nivolumab, or Opdualag. There is nothing in the tumor itself that we test to determine whether or not a patient should receive immunotherapy X, Y, or Z. We make our decision based on the subtype of the melanoma, based on the extent of the disease, based on how the patient is doing. But you probably know we're actually not checking PD-L1 in the tumor. I don't care, because whether it's high or low, as far as I know, immunotherapy is still the best treatment, and this is what I'm going to utilize until I have a biomarker sufficiently robust to tell me otherwise. So we use immunotherapy now, even though melanoma obviously was the first place we use it in a lot of diseases. And in fact, immunotherapy is the first time that we saw what we call tumor agnostic approvals, meaning regardless of what type the tumor is, if there is a certain biomarker there have been these clinical trials done whereby FDA has said, for example, if a tumor has a high tumor mutation burden, that means that the tumor is very heavily mutated. This is something we test in the lab. And if a tumor is super heavily mutated, more than 10 mutations per megabase of DNA, you can use immunotherapy. Whether it's pancreatic cancer, brain cancer, whatever, it doesn't matter. This is very particular to immunotherapy, but I want to say even in this context, and there's a lot of literature about this, it is still not an ironclad biomarker. Having a high TMB or tumor mutation burden absolutely does not guarantee you a response to immunotherapy. Another biomarker that we look at is microsatellite status, which is basically a long-winded way of saying how the DNA repair mechanisms work. So all of us, as we divide our cells, DNA machinery makes mistakes. This is normal. The question is, can your immune system clean it up or not? So for patients who have microsatellite unstable tumors that have a lot of mutations, this is another place where, regardless of the tumor type, you use immunotherapy. Again, this is another place where microsatellite status is not an ironclad biomarker. All of that to say there's no always or never. We also use immunotherapy much earlier. When I was starting, we were doing the clinical trials, we were running the clinical trials of immunotherapy in stage 4. We then ran the clinical trials of immunotherapy in stage 3, and we showed very clearly that there was a benefit to the risk of recurrence. Most recently, we led the trials here for immunotherapy in stage 2. Again, we showed that there's a significant reduction in the rate of recurrence. However, and I say this to every patient, you can get immunotherapy for stage 2 or 3, and your melanoma might still come back. We don't know who's who. Similarly, you could opt not to have any immunotherapy for stage 2 or 3, and it could never come back. So when we're talking about these clinical trials, we're talking in averages. We're saying in an average population of so many hundred patients, those who got immunotherapy did better than those who didn't get immunotherapy. But again, we still don't have a way of predicting who's who. And this is in the context of metastatic disease, stage 4, but also earlier stage 2 and 3. You can appreciate as well in the adjuvant setting, meaning when you're giving immunotherapy as a cleanup job after surgery for stage 2 or 3, a predictive biomarker, I would argue, is even fundamentally more important because the risk of toxicity, while always a concern, regardless of the stage, I would argue is even more of a concern in a patient who's potentially cured by surgery alone. So this is a place where we really are in dire need of a biomarker. There are multiple biomarkers under investigation, and as I alluded to, ideally, this would be something coming from the peripheral blood. This was a very nice review that was recently published. They looked at hundreds of studies and then put together data from about 140 of them. And this is basically the sum total of all of the things that are hinting in one direction or the other. But again, none of this is being utilized in routine practice. This is still very firmly in the realm of research. We know that when looking for biomarkers for reasons that I mentioned, we think that peripheral blood is of particular interest, and we've become increasingly focused on glycosylation. So glycosylation basically means that the protein, protein has this sugar moiety or sugar molecule sitting on it. And about 70% of proteins are glycosylated. And so this is data that we presented at a meeting very recently. But the reason I think glycoproteins are of particular interest is that there's simply so many of them. And you can appreciate that by expanding the repertoire of whatever you're looking at, you may have a higher chance of alighting on something of significance. So this is basically to show that we developed this, this platform has been developed by this company with whom we've been working very closely. And you can run this assay on 100 microliters, a tiny, tiny bit of blood from an individual patient. And because you're generating so much data by looking at glycoproteins, this is where the AI part becomes very critical so that you can actually analyze this huge amount of data that you're generating. And what was done was basically we assessed close to 600 biomarkers. And without getting into the weeds about it, I'll just say that we took a very small amount of blood from patients before they started any of their immunotherapy treatment. And these were patients with stage 4 melanoma. And we basically looked at multiple iterations and went on to develop a particular signature. When I say signature, I mean we identified a number of glycoproteins, looking at proteins in the blood, looking at sugars on proteins in the blood, that when you put them together, could help us predict who was going to benefit from immunotherapy and who wasn't. And this was started off by looking at a discovery cohort. So we had blood from 202 patients, and you basically break down the cohorts into different numbers. This is all statistical modeling that's done by people certainly much smarter than myself, but you break it down into a training set, a validation set, and then you blind yourself and look at it in a test set and an independent cohort. And this is all to add layers of rigor to the analysis that you're doing, to say that when you find something, if you find something, as Mary so clearly put it earlier, it's not up to statistical chance. This is actually a meaningful result. And I want to point out, like I said, that all of these patients were drawn pre-treatment, and we had patients with stage 4 disease. So when we did the statistical modeling, which is to say when we set out the question we were trying to answer, the question we were trying to answer was, can we use the signature to predict? So this is what I meant earlier by predictive biomarker. Can we use this signature to predict, very bluntly, who's going to live and who's going to die? And while that was the number that the way that we were modeling the data set, we actually broke down the data into 3 categories. What are the clinically meaningful categories? One is patients who just derive no benefit at all, what we call early treatment failure. 2 is patients who have intermediate control, meaning they have some benefit, but certainly not nearly as much as we would like. And then patients who have sustained control, the cases where the cancer is eradicated or controlled for at least 3 years. And what I want to show you here is by breaking down all of the glycopeptides, I'm just going to break it down for you by color, we were able to distinguish who is going to respond from who is not going to respond. And when we tested the actual performance of the model, asking ourselves, can we predict who is going to die with this disease? The answer thus far seems to be yes, in this training, validation, and test sets. And when we took the signature and looked at it in a totally different population from a different continent to try and be as stringent as we could with the data, we looked at it in an independent set from patients from Australia, actually. The model still held up quite well. So this is really the very first step, certainly, in what's going to be a much longer story. So on the right-hand side here, you can see some of the key clinical trials of combination immunotherapy. When I say key, I mean phase 2 or phase 3, that certainly were on the radar of all of us in the field, with major readouts that we were waiting on, many of which have led to approvals and many of which frankly have led to flops that were quite disappointing. What's missing across a lot of them is biomarkers. So you can see in the red, this is where I basically asked myself, did this trial have a biomarker? Was there a biomarker buy-in for the patients when they were going in? The answer, more often than not, is no, unfortunately. And so one of the many problems in our field right now, although certainly there's a lot of good, but one of the problems is that with so many clinical trials combining different drugs, different agents, different modalities, we need to be very thoughtful about this not being spaghetti on the wall. We need to have a very clear scientific rationale, a translational rationale. When I say that, I mean data coming from the lab to the clinic, from the patient to the lab, to tell us why we're combining A and B. We need to have a very good reason for doing so. And this is where biomarkers may come in. Historically speaking, we've really just looked at the tumor. That's where we started. But now we're understanding increasingly that we need to look at the tumor, that we need to look at the tumor microenvironment, meaning the tumor tissue and everything around it, everything within it. We need to look at the host, the patient. What's their microbiome, as we'll hear from Dr. Devar? What's their metabolism? That's a huge interest in my lab. What's their BMI doing to the tumor cell metabolism? What's in the peripheral blood? We need to put all of this together, ideally. I don't doubt that it's not going to be any one thing, to develop a robust predictive biomarker. And ideally, what we're all working towards is to understand all of these factors and tailor treatment accordingly to a patient's individual tumor characteristics, which certainly is not a stagnant thing. It's a very dynamic, moving target. The tumor is different, not just from a liver tumor to a lung tumor, but different regions of one liver tumor are absolutely different. There are different immune cells, there's different oxygenation. And so this is what you may have heard referred to as tumor heterogeneity. No two tumors are the same. No two parts of one tumor are the same. So you can see why this has proven to be such a complex task. So I'll finish where I started. Can we predict who will respond to immunotherapy? The short answer is not yet. But I didn't want to lead with that. I wanted to explain to you why I say that. Prognostic biomarkers, as I alluded to earlier, have declared themselves. We know liver mets are harder to treat than lung mets. We know brain mets are hardest of all. We know LDH that's very high is not a good thing. So we've learned just from having had the privilege of treating thousands of patients what the prognostic biomarkers are. We've learned about the disease. What's missing is to understand what biomarkers, what factors, if you will, can predict response. One thing that I had put in here, and I apologize, this PowerPoint didn't make it in with the 2 slides I wanted to add. One area of interest in my lab is looking at oxygenation or hypoxia in the tumor. And by understanding that, we actually think that hypoxia may be a predictive biomarker for a new kind of treatment. And so we developed this clinical trial that we have run here. We actually just finished enrolling it 2 weeks ago, combining medication that targets hypoxia with immunotherapy to try and overcome resistance of the tumor to immunotherapy. So that's an example, you know, when I say translationally driven, lab-driven work, that's what I mean. Any biomarker that we come up with will need to be very robustly validated so that we are sufficiently confident when we tailor treatment decision-making. It needs to be ironclad. This is a hugely active area of research. I hope I've given you a flavor of that. And our results that I had shared with you show that this circulating glycoprotein signature, which is 14 glycoproteins, does appear to be related to overall survival, but I really don't want to make too much of this. It's very early days. And we are now working on writing the grant to prospectively prove this. So the first thing is you look back at a data set, you say, this looks interesting. And then you want to look at it prospectively to see if it's true or not. And so that's where we are. And so prospective studies are being planned. The last thing I'll say is I really just hope I imparted a very little bit of a flavor. I mean, this is certainly something we could talk about all weekend. And this is the very tip of the iceberg. And I'm sure there's a lot more to come. I'm happy to try and answer any questions.
Hi, a couple questions from Zoom. In the treatment of stage 4 melanoma using Nivo, will a booster dose be necessary to prevent recurrence? In other words, does immunotherapy clear the body and leave you vulnerable?
I'm not sure what you mean by a booster dose, but for Ipi-Nivo, what we do is we treat with 4 doses of Ipi plus Nivo, and then we continue with Nivo for up to 2 years. We do tell every patient that you may not get through all 4 Ipi-Nivos. In particular, it's the Ipi that's quite toxic. And we tell every patient that there's no data to tell us that 4 Ipi-Nivo is better than 3 or 2. We tell patients get through what you can get through. And if what's meant by a booster is more Ipi, I would say no. The Ipi acts very early on in what we call the cancer immunity cycle, which is to say that it's acting on the first step of your immune system recognizing that there's a problem becoming activated. And I think Ipi is a very good example where more is not more.
I had stage 3 cancer last year. It was removed, followed by immunotherapy. All scans clear. Another tumor has grown in the same place. Is immunotherapy done again?
Is immunotherapy done what?
Done again.
Yeah, first of all, I'm very sorry to hear that. Is immunotherapy done again? Maybe is the short answer. It really depends very heavily on exactly how long it's been. Is this surgically resectable? Usually when a melanoma tumor comes back in the same area and there's no sign that it's spread on the inside, we will often lead with removing that tumor surgically, and we may then talk about whether we think there's benefit for further therapy. Immunotherapy, the second time round for stage 3, as far as we know, is not as effective as the first time around, but depending on the time that's passed, that may be considered. Another option your physician might take is to give you 2 kinds of immunotherapy up front and then do the surgery and then give you more immunotherapy. But really, it depends on a lot of the details of the individual case.
Another question from a patient on Zoom. I have a stage 2C melanoma. My oncologist did not suggest immunotherapy. Should I get a second opinion?
Maybe, and I say maybe because if, you know, the reason, and certainly not every patient with 2B or 2C will get immunotherapy. And we have this discussion with every patient, and we talk about the risk of the treatment versus the risk of the cancer itself coming back. And if you have any autoimmune disease, if you have an organ transplant, if you have a lot of health problems, there may be an excellent reason that your physician did not recommend immunotherapy. But I think it's something that certainly warrants a discussion. I obviously don't know the particulars of the case, and that's why I say maybe. But I would hope that this is a discussion we are having with the patient to say this is something that's approved. We can use Keytruda, we can use Opdivo. This is both standard. There's nothing experimental about this. And certainly I have many patients say, no, thank you. And that's totally okay. But we have that discussion.
Also considering outside environmental possibilities that are still contributing to an undesired result, such as an example, spray shampoo causing cancer, you can recall, you guys are doing all your best, you got the data, you got the science, you're doing great, and then you're like, what is going on? Are you also looking at environmental outside factors that could be skewing your results, even though you're right on target?
That's such a good question. And the short answer is no, and I'll tell you why. These factors are very difficult to account for. What I think Mary did a beautiful job in her talk of imparting was the rigor which is required. When we stand up at a meeting like SITC, which is a major meeting, and you disclose the data I was showing at the scientific community, this is something that has to be done in the most rigorous, most clean, most reproducible way. I don't know how I can measure whether somebody is eating organic berries or sprayed with pesticide or dry shampoo or aluminum in their deodorant, et cetera, et cetera. I don't doubt you're wrong at all. I don't doubt whatsoever that environmental factors are a major problem. They're just very difficult to account for at the level that is required. I will say one thing that's being increasingly looked at is diet. And this is something MD Anderson has done very well. That they did this study where they basically controlled the diet of the patients completely. The patients on immunotherapy got food only from them. They ate nothing else. And they actually showed that a high fiber diet is associated with a better outcome. The person who led that study is a friend. And what she said to me is it's one of the hardest studies she's ever done, because of having to account for every possible difference. Does that make sense?
So Anne has a question.
I have another question. I keep getting closer to you and closer to you and closer to you. I'm so sorry.
I'm hard of hearing, so I really don't mind.
So this is another Zoom question. I'm currently NED. What if I would stop the tabular mechanism altogether? What are the odds it will return?
Well, it depends on the context. If you're NED and you're on TAF-MEC because of the trial that Dr. Kirkwood led, COMBI-AD, I would say without question, finish out the year. And then the chances of it coming back are low and the odds are very much in your favor. If you're on TAF-MEC for stage 4 disease and you're NED, that's wonderful. And I would say keep going if you're tolerating it, because we do know that when we stop targeted therapy like TAF-MEC, there is a very high likelihood of the cancer coming back. So this is part of the pros and cons. Immunotherapy doesn't work as well as targeted therapy, but you have this durability, meaning even when you stop, the benefit is there. Versus targeted therapy, it works beautifully for most patients with a BRAF mutation, but then it does not work if you stop the medication.
And I think one of the key questions that all of our patients will have is, do we have to continue coming in for PET CT scans until we can't stand coming in? And that ruin a week, sometimes more, before each of the scans because of the anxiety about what's going to be found on the next scan. And the answer is, as Dr. Major mentioned, blood tests for the glycome or circulating tumor DNA are now being explored. We're sending hundreds of samples from our clinic in hopes that these will displace the PET CT scans, the CT scans, and that these can be done from the comfort of your local Quest laboratory, not requiring you to come in. Already in other diseases, the ctDNA, the footprints of the tumor in the blood, are being used in preference to PET CT scans. In melanoma, that hasn't yet been possible because we don't know to adequate confidence that that suffices. But I think the future is not too long down the road that we'll be able to do these things and not need to do PET CT scans. So we've made it to 10:07. I think we'll take a break for maybe 15 minutes, and at 10:20 return here. We will then hear about the gut microbiome and interesting new approaches that Dr. Devar will present, and follow that with a discussion on pediatric melanoma from Dr. Sanava, and then further questions.
Hey, Doc.
Can I email you the slides, or I have my computer?
Yeah, we're kind of tied
Yeah,
in to
so
this.
can I just email them to you? Can you
Sure,
put them in?
or OneDrive.
Yeah. There.
Something going on. Yes.
Because our online. Can we have a second microphone, and then that way our two volunteers are gonna get them around the
Got
room.
that, the amplifier hits these, we'll be good, we'll be good, thank you.
I've become really saved our butt because our whole disease system is doesn't do it for struggle. Right. I have very little to do. We know about the car, and we don't know until we wait for passion. A bicycle. My dermatology is not very friendly and I was working down in North Carolina, but I don't know. I mean, it's hard to get my sister on call for GE where I started.
once they're there, so.
But down there, somehow, first time we get first, it was all here.
Yes.
She.
That's all it's.
Doctor. North Carolina, it's like playing back. What is numbers?
I wish I could.
You not.
You just got. Just got that. Wait. Yeah, I mean, honestly. I was just at the PRG. But Alberto, that was just fast. And I'm just melanoma concept. That'll be the first time we'll have it. If it's all safe, so. Start and yes. So. Save it for there was, you know, there's this. Yeah, no, I mean. Right. Only line.
It should be. And you can't be $8 for it. Very. Yeah, the lady walks next to me in my office, she says, thanks for coming. Yeah, exactly.
If we could muster everyone back to their seats, I think we're live on the video stream. And our next section of the program will be commenced with Divakar Devor talking on the role of diet and gut microbiota in determining response to immunotherapy in melanoma. Welcome.
All right, people can hear me, right? Good. Disclosures. All right, so the whole idea is for this to be somewhat interactive. So if you have questions, if the people on Zoom have questions, you're welcome to interrupt and ask. And I am happy to take them at really any time. So kind of why we have started focusing on this area is really because of all the stuff you've already heard, right? So the point is that in this disease, we're now curing about 40% of our patients, which is great. It's outstanding. Like 40% of patients with advanced cancer do not need to worry about their cancer coming back after we put it into a long-term remission. Our only problem is that one, we don't know who those people are. That's why you heard the talk about biomarkers. And two, we don't quite know how to make it better. And so we've got these new treatments. TIL, for example, has just been FDA approved. And presumably those patients will do well long-term. Certainly that's the data from the Steve Rosenberg lab. But what we are seeing is an inflection point for the first time in a long time where our patients are durably surviving. The question is, how can we make it better and how do we know this is to be the case? So the first and the most interesting thing I want to show you guys is actually data from the public domain, right? So how do you know that we're doing a good job? We know we're doing a good job because for the first time in recorded history, the national death rate for melanoma is going down, which means that unlike every other cancer, right? For example, uterine cancer or non-melanoma skin cancer, where the death rates are going up, in melanoma, the death rate is going down. And the only reason it's going down is certainly there's some targeted therapies that are helping putting people into long-term remissions, but it's also predominantly the immune therapies that are really doing a lot of that work. And so as we start to think about why this might be the case, we really have historically focused on three things. You know, you look at the cancer, then you look at the people who get the cancer, but nobody's really looked at the stuff inside the people that get cancer. And that's kind of what our group is focused on. So the question really is, why do we do that? And the answer is very simple. It's a math problem. All right, it's a math problem. So the human genome, right, all 23 copies of you and what I and all of us have contain about 24,000 genes. Well, it turns out you need about 30,000 in order to survive. So where does the 6,000 come from? Well, as it turns out, you can't walk around with it in your wallet. And it happens to be in the gut bacteria that you have. And really what this is, it's a symbiotic relationship. We have them, they have us. They feed literally kind of like your 20-year-old kid in your basement. They feed off you. And what we do is we need them in order to be able to use that bacteria for certain things like vitamin K. We don't produce vitamin K. Humans need vitamin K. Where do you get your vitamin K? From the bacteria. So as it turns out, we've been using them for a whole host of things that we've known about. But what we're now realizing is that they may actually help immune therapy work a little better. And how that happens and why it happens is what is the focus of our group. So really sort of 4 parts to this, and it's really meant to be very simple. And they're broken it down into 4 things. So the first thing is, what can you take in that affects how these drugs, the drugs that we're giving you, work? 2, what are those bugs and how do they make things work or not work? 3, can you try to change that? And 4, what do you want to remember if you don't remember anything else of what I've said? So simple stuff, antibiotics, bad, right? So why do we know that antibiotics are bad? Well, we've tried it in mice. Now, again, if you do mouse work, you know that you can make almost any tumor smaller in a mouse. You just need to squeeze it hard enough. But people have shown that in mice that get, in a cancer model of mice, that the receipt of antibiotics can depress the effect of immune therapy. Then humans, studying other humans, have done meta-analyses that have shown that when you look at the recent receipt of what are known as broad spectrum, so not narrow spectrum, but broad spectrum antibiotics, we reduce the likelihood of people developing responses to cancer and people having poorer cancer outcomes, especially if they're treated with immune therapy. And certainly this has now been also shown for CAR T therapy, that is cellular therapy, in data from the Penn group. Macronutrients, you heard here earlier from Dr. Najjar about the study in MD Anderson. So they have shown that, for example, there's a certain inflection point when it comes to fiber. And certainly when you give people a permissive amount of fiber, what is thought to be about 20 grams a day, you certainly have slightly better outcomes in patients who receive immune therapy compared to not getting that minimum amount of fiber. Certain people looking at, in a healthy donor patient setting from a group in Stanford, showed that fermented foods, so not necessarily just high fiber, but foods that are rich in fermented products, can also have non-overlapping positive changes on the gut microbiome as well as the host immune system. And the key thing to keep in mind here is that fermented foods in this context are typically things like sauerkraut and kimchi, not beer, right? So it doesn't mean to say that if you go get a keg, you're going to do better than the guy who didn't drink a keg. But what we're looking at is really the intake of high fermented foods at a sufficient quantity for a sufficient period of time. And in addition to that, increasingly, we've got data that is looking at non-nutritive sweeteners. And non-nutritive sweeteners are all the stuff that is out there, right, on the extreme right of the coffee thing, where it's things like Splenda, Sweet and Low, NutriCal, NutriSweet, Equal, all the stuff that we've been taking ourselves and telling ourselves that it's better to take than sugar. Well, it turns out it's actually quite bad. And this was certainly shown in a very elegant preclinical paper from the Crick Institute. So you can see here that mice that get high amounts of non-nutritive sweeteners do a lot worse. But we try to do a simple experiment here, right? So we said, you know what, the FDA must know what the right limit is. How can they possibly not know? So it turns out the FDA limit of sucralose, aspartame, acesulfame, and saccharin are all listed there. But let's just talk about the sucralose daily limit for a minute. So sucralose is a sweetener that is typically found in Mountain Dew. I use the term Mountain Dew because I used to drink Diet Mountain Dew, and I know it gives you a great rush, which is why it's fantastic. And sucralose, the daily limit is about 5 milligrams per day. And so part of the reason why we studied it was because it was one of the drugs that the FDA thought actually had a very low limit that was considered to be safe in humans. So you can see aspartame 50, sucralose 5, right? So we said, you know what, it can't possibly be that bad. So let's just look at how people do. So we'll take the amount of sucralose people are taking in. And so the way we calculate this is, I've got a couple of people that work for me, for my patients and other patients that have been seen by Dr. Najjar, Dr. Kirkwood. These are the little people that come up to you and they ask you these annoying questions and they keep persisting and they keep asking you stuff until you give them an answer. And they hunt you down in the parking lot. And then once you give us that answer, we then take that information, we put it in a computer and we separate it by your weight and we come up with a number. And then we see how people have done, right? So what I've shown you here is the daily limit. So the sucralose daily limit is there on the right. So the first thing you see is that the vast majority of the people that are telling us how much they take are not eating very much, right? The daily limit is 5 milligrams per day. The vast majority of what people are taking is about 0.2 of that. So the vast majority of everybody that we ask this question to are taking about 10% of what is considered the daily limit. And when you use that as a cutoff to look at how people have done over time, firstly, you realize that it actually affects how much you do quite a lot. So when you look at the people who are taking just 10% of the daily limit, again, the daily limit is 5 milligrams, and we use a cutoff of 0.2, so that's approximately 4% of the daily limit. When we looked at 10%, it was poor. When we looked at 4%, the difference was quite stark. And this is actually suggesting that if you take sucralose at a certain dosage, you can actually negate the effect of immunotherapy, but quite a bit. And the way you can think of that separation of the curve is that separation of the curve is exactly what CTLA-4 does to checkpoint, right? So when you take a CTLA-4 inhibitor, you improve your likelihood of responding by about a hazard of 0.7. Taking artificial sweeteners just negates that, right? So artificial sweeteners, probably pretty bad for you. This data is actually, we've now replicated this in a mouse model, and we think it's probably to do with a certain key amino acid known as citrulline and arginine, and this work is currently being submitted to a journal. So what else, right? So if the stuff that you take can affect the bugs that you have, then what bugs are good or what bugs are bad? So as it turns out, you know that people who do well, we've shown, other people have shown, that people who do well and people who don't do well have very different bugs. And these bugs are quite interesting. So again, most people here don't really care about bugs, but I care about bugs. But most people won't remember that I care about bugs. But the short answer is there are a whole bunch of different bugs that are very, very, very interesting, right? These are all these different bugs, and you see a lot of them. Most people think of things like the stuff that's in the back of, the yogurt. And certainly those bugs tend to be good to some extent, but there are lots of bugs that you may have heard about that are in these probiotics that you take that actually show up in the stuff that's bad. And the short answer is that we think that you can essentially develop a signature of what's good or what's bad, or who's going to do well, who's not going to do well, and I'll show you some data about that. But the key point is that reliably, multiple people here, Europe, MD Anderson, Chicago, Montreal in Canada have shown, actually even the Koreans have shown, that the bugs of people who do well across a variety of cancers treated with immune therapy are very different from the bugs of the people that don't do well. And the question is why, right? What is it about these bugs that do that? And it really turns out that what the bugs do, if you happen, for no reason that you necessarily can control, if you happen to have a series of adverse organisms, right? It's kind of like you can't control who to a large extent, you can't control the bugs that you have. It's kind of like saying, I kind of wish I wasn't married. Or my wife's second cousin wasn't this crazy person, because again, you love your wife and you got married to the person, but she's got an idiot cousin. You can't do anything about that. So the bugs in many ways are like that. You have very little control over the things that show up. But those bugs can, if they happen, right, again, cousins being cousins, if they happen to be bad, they can exert a very deleterious effect. And the reason they exert the deleterious effect is because they produce and they engage in a crosstalk with the host immune system to increase what is known as a myeloid tone, or the inflammatory tone, and it raises your body's inflammation level. So people may know a little bit about immune therapy, they may know a lot about immune therapy, but certainly people have heard that inflammation is a bad thing, that it's a bad word. And that inflammatory state gets jacked up when you have certain key microorganisms that are adverse. And those bugs that appear to do that, particularly gram-negative rods, and those adverse microorganisms produce inflammatory cytokines such as IL-1 beta, CXL8, and certain things that essentially raise that inflammatory tone up. So when your immune therapy is trying to work, the bugs are actually working against that. So you're trying to do something, you're trying to get a drug, the drug is trying to turn on the immune system, and these bugs, they're just subverting that. And as it turns out, we can look at the genes and we can find the genes that do that, and certainly the genes that appear to be good are genes that essentially enhance your immune system. They alter the certain immune cells that are present that actually help the body's immune system work a little better, particularly what are known as MR1 restricted T cells and MATE cells. And then the bad genes that are found in the bad bugs, those genes essentially produce more LPS. And LPS essentially is lipopolysaccharide, and lipopolysaccharide increases that inflammatory tone. Now, we can also find bugs that are different in people who have side effects. So again, the people who get immune therapy, people who do well in immune therapy, don't do well in immune therapy, then the people who get immune therapy and do well or not do well from a side effect perspective. And when we look at the people who get side effects, we see that there's a very, very different gut microbiome signature amongst not just one side effect, meaning side effects versus no side effects, but you can literally fingerprint each side effect. You can say, you know what? This person has colitis. This person has a thyroid problem. This person has a neurological problem. And we have all these different side effect profiles. And the one side effect profile that's actually very, very interesting is a side effect known as arthritis. And the reason arthritis is very interesting is because the microorganism that tends to be associated with arthritis is this bug known as Streptococcus. So again, Streptococcus is not necessarily an organism that many people have heard of, but certainly if you're in your 60s and 70s, Streptococcus is the reason why we have what is known as strep fever. And Streptococcus in the 50s and 60s used to be a common reason why people ended up with post-streptococcal infections that caused arthritic problems, but also cardiac problems. So strep is actually kind of well known in the medical space because people develop essentially post-streptococcal autoimmune problems that cause kidney, cardiac problems. And Streptococcus is not found in the gut. It actually can't go into the gut. And the reason it can't go into the gut is because it's an oral commensal. It's only found in your mouth. And for it to go into the gut, it must mean that somebody is taking something that facilitates that, because it's killed by the low acid, the low pH or high acid environment of the stomach. And as it turned out, when we looked at that, we found that indeed to be the case because Streptococcus was only found in the people who took proton pump inhibitors. So another thing that's probably bad for you, that big guy that goes around on that ad on TV that says that you can buy Protonics at CVS, not a good idea. Protonics, bad. So finally, can we do something about this? Well, we talked a little bit, you heard a little bit about diet. People ask me all the time, can I do something about my gut microbiome? And the answer is a whole bunch of people are doing a whole bunch of things. So this is just a list of interventions that people are studying. There's everything from fecal transplants to consortia to dietary changes to monoclonal, what are known as monoclonal microbial candidates, where you just take a single bug and you try to give that to people. And I'll just give you a brief version of what people have looked at. So this is something we did, right? So this was a piece of work that was done here. And about 6 years ago, we started this experiment. It was very simple. It was just a proof of concept study in which we took people whose cancers had not responded to immune therapy. Actually, the very first person that was treated was Dr. Kirkwood's patient. And we gave those patients immune therapy, and we just gave them a different gut microbiome. We borrowed the gut microbiome from somebody who had done really well on immune therapy, and we matched these people up by just checking the presence of certain key organisms to make sure they wouldn't reject that. And rather unsurprisingly, 9 people didn't benefit. But what was quite astounding was that 6 people who did not respond to Keytruda, did not respond to Opdivo, did not respond to Keytruda plus Opdivo, responded to Keytruda plus gut microbiome change. So all we did was we gave people a single fecal transplant, and 6 people started responding to Keytruda. So we're not here to say that you should, A, go on Amazon and start buying the reverse engineering kit that is designed to be able to do, fecal transplants at home. That's a terrible idea. Do not do that. We also don't necessarily think that you can start getting fecal transplants at the GI doctor's office. I certainly get calls about that. We think that certainly this proves that if you have a bad microbiome, then you're more likely not to respond. And maybe there's something we can do about it. We've been able to prove the reason why this works is because of certain inflammatory cells that are bad, myeloid cells, and certainly the people who do well on this tend to do well long term. In a more recent experiment, a bunch of guys in Montreal, actually across Canada, gave people a fecal transplant derived from healthy donors, right? So these are young college kids. Those are the only people who are willing to poop for $50 a pop. And they took the poop from these young college kids and they gave them to people whose cancers were growing, who are candidates for Opdivo and Keytruda. And those people were given just Keytruda or Opdivo by themselves with 1 fecal transplant, right? So the standard response rate of Keytruda or Opdivo is about 35 to 40%. And in this study, they got the fecal transplant from 3 healthy donors. They treated 20 patients, and 65% of their patients, 13 out of 20, had radiographic shrinkage. And certainly those people have done very, very well for very long periods of time. This paper was just published. And a key aspect of that paper was something that we had shown about 4 years ago now, which was that the people who responded to a fecal transplant had what is known as engraftment, meaning the bugs that you got from somebody else survived. And then it's kind of like a transplant. It's any other transplant. You get a stem cell transplant. If your donor cells are not present in your bone marrow, they know your leukemia is coming back. They know the lymphoma is coming back. And much like this, if you get live bacteria from somebody else and the bacteria doesn't survive, it ain't working. So finally, what can we do about this? And what are people like me and other people doing about this right now? So a couple of things. One, we certainly think that immune therapy to a large extent, is curative for a whole bunch of people. The problem is that we have a tail to the curve, and that fraction is only 25% for PD-1 monotherapy, 40% for PD-1 CTLA-4. We don't quite know what the durable tail of the curve is for PD-1 LAG-3, and certainly we're curing more people with TIL, and with the addition of some targeted therapies that is improving those odds, but it's still not everybody. And we're not going to be able to sleep at night until every single patient who has advanced disease is cured. And we think that clearly a large fraction of these people, 30 to 50%, are failing in the first 6 to 10 months, which is when we think the gut microbiome is probably exerting a greatest effect based on our data. And what we're trying to do, and what we think is happening, is that the beneficial microbes are needed to sustain immune therapy. But when you have a set of bad bugs, it's kind of like your wife's crazy cousin. The wedding doesn't go well because this person just disrupts everything. So what we're trying to do is we're trying to do proof of concept experiments to extend that. So certainly we've done this in refractory melanoma, that's already been done. There are now larger trials that are happening. In fact, the NCI is getting ready to think about a larger call for a national trial that we are involved with. And 2 independent experiments have shown this, both Israel and here. Israeli data is on the left, our data is on the right. And we've also now seen this from a Canadian group in an early study of a non-randomized phase 2 in advanced non-refractory melanoma. So what we are doing, actually, this trial is already open. We're hoping to accrue patients to it. And it's basically pembrolizumab and lenvatinib, which is a good combination in the refractory setting. 20-something% of people respond to this. And half of these people are going to be getting a checkpoint inhibitor with the lenvatinib. The other half are going to be getting the same thing with the fecal transplant to try to get the response rate closer to 50%. And so this trial is open. What we're also doing is we're trying to develop an actionable biomarker, right? So we're looking at a whole bunch of people. And so the exact same people that get asked the question about whether or not you're taking high amounts of sweeteners or not also are asked to give us a stool sample. We've now profiled about 1,000 patients. And we're working on that data set right now. And we're looking at, again, the biomarker. And the whole idea is we want to see people who do well, right? So we know that 40% treated with 1 drug, 55% treated with 2 drugs are going to do well. And we think that the balance of the microbes, right, affects that probability. So if you're more good than bad, you tend to do well. And if that's the case, and we prove the biomarker works, and we have nothing more than we tell you that, you know what, you're already doing well. You don't need any help from us. But if we find that you have bugs that are bad, you need some help, right? And the question is, what is that intervention going to be? And we're working on that right now. We think it could be a gut microbiome transplant, a couple of new bugs. It could be a couple of key consortia, a couple of keystone consortia. Finally, side effects. Side effects are a huge aspect of what people who have treatment have to deal with, because it's one thing to put somebody into remission, which is good. It's another thing to put somebody into remission and have them live with long-term side effects that they are now living with for the rest of their lives. Because if the immune therapy is working and is producing a lifelong remission, certainly the side effects are also equally, unfortunately, durable. And we certainly are seeing a lot of these side effects more often, particularly because 2nd-generation CTLA-4 inhibitors have been developed. So we've now got drugs that are producing remissions in colon cancer, microsatellite stable colon cancer. These are newer active agents from companies like Agenus. The problem is that when these drugs produce these effects in patients with colon cancer, and they work extraordinarily well in patients with melanoma, the reason they work better is because of some engineering that was done to the drug, but these drugs produce a bucket load more of side effects. So we really think that side effects are an equally important part, because we not only want to cure every single patient, we also want to have every single patient not have to live with long-term side effects. How do you do that? You have side effect trials. So what we have right now is a clinical trial where we're giving people a microbiome modulating agent to essentially eliminate side effects. And the idea is that if you have bad side effects, particularly skin or colorectal side effects, we'll enroll you in the trial, we'll fix your side effect. We think it's going to be about 40 to 50% effective in refractory patients, maybe 60 to 80% effective in patients who've not even had a biologic. So we think it's very effective in biologic refractory patients, but we're looking to study it earlier in order to try to prevent people from getting side effects. So the final thing, very simply, is what should you do? If you don't remember anything else, what should you eat or what should you not eat? So again, I'm not a nutritionist, so I can only tell you data that we or other people have generated, right? So we can say, what should you kind of sort of avoid, and what should you maybe eat more of? So I think clearly artificial sweeteners are bad, right? And we think it's bad because of data that we've generated, other people have generated, but you know, these things are not a natural product. You don't find them in strawberries. You don't find them in blueberries. You don't find them in a natural, they were made by DuPont. So I think that what we are concerned about is that the engineering behind these agents was just not designed to ensure that we know that it's going to be safe with everything else that people need. It was created as a substitute for sugar in the 1980s. The antibiotics that are given broad spectrum without concern for people being currently on immunotherapy is probably a bad idea. So the main thing is your oncologist is your best friend. And so if somebody is trying to give you something, maybe run it by your oncologist. What is good? Fiber is good, right? Do we think people are eating enough fiber? No, right? You know why? Because you know the USDA tells you to take 38 grams. How much are most of us eating? 15. So most of us are not even eating what we're supposed to eat, right? So if we ate a little bit more of what we're supposed to eat, we'd probably be thinner, we'd probably be healthier, we'd probably have less cholesterol, we'd probably not be fat, and we'd do better with immune therapy. So eat more fiber. Fermented foods might be good, and again, not beer, probably kimchi, sauerkraut, yogurt, things like that. The Mediterranean diet might be good, but again, you don't need to do this for your immune therapy. Mediterranean diet is good if you have cardiac disease, if you want to lose weight, if you want to have a lower glycemic index, if you want to have better outcomes from a BMI perspective. So many of these things are actually just commonsensical things that you should just do right now because you should already be doing them. So we don't, and we are certainly thinking about doing dietary trials to try to enable a better understanding of the space. And certainly my colleague, Dr. Zaror, who's the co-leader of the program with John, is engaged in some of these things. So these are my acknowledgements. We're very grateful to the patients that put up with our nonsense and answer our questions and give us stool specimens, because we literally, it's a stool study, right? So we literally cannot do this research without you guys. So thank you for agreeing. Thank you for pooping in a cup. Thank you for not giving us your dog poop, because that's one thing we can tell. And many of these things are fascinating because, this data, a lot of the data that I showed you is actually generated right here, right? So we're generating all of these things here with your help. So thank you. Happy to take any questions. And I did not go over time.
Question number one.
Yeah, I have a question from the Zoom.
Yeah.
For patients who develop colitis on immunotherapy,
Yep.
does switching to a bland, low fiber diet control the colitis, reduce the efficacy of immunotherapy?
Okay, so I think there are two parts of that question. The first question is getting colitis, and then two, what should you do about it from a dietary perspective? So the getting colitis part is unfortunately something at this point in time that we can't prevent. We are hoping to try to think about prevention strategies in the future. Certainly, Jeff Weber has run a trial where everybody got ipi-nivo versus ipi-nivo plus tocilizumab, and the tocilizumab arm had slightly lower colitis side effects, but it was not eliminated. That's tocilizumab is an anti-IL-6 agent, so we don't think we're at the stage of preventing CTLA-4 related colitis just yet. We think maybe in the future, yes. The primary treatment is steroids. It's not dietary change. It's steroids to reduce the immune suppression. Maybe investigationally, you can think about getting some kind of microbiome agent. The idea behind a bland diet mostly comes from inflammatory colitis that is not immune mediated, meaning inflammatory bowel disease related colitis. In the context of IBD, yes, there is some decent data that a bland diet, what is usually termed a low residue diet, helps with colitis mitigation. That data is not present for immune therapy related inflammatory colitis. So the point here is that no two inflammatory pathologies are alike. They're just not the same. The trigger is not the same. The underlying mechanism is not the same. The cells that cause the inflammation are not the same. The treatment's not the same. So the short answer is a bland diet is probably not going to help somebody's severe inflammatory colitis. So what you need are probably steroids. But the key question is the biologic. And the problem is in the steroid refractory setting, many people switch to either vedolizumab or infliximab. And the concern that we have is vedolizumab, which is an alpha-4 beta-7 inhibitor, was thought to be actually the better biologic, but there's some pretty good data from a recent paper by Laurence Zivager, it was in Science 2023, that it's actually worse. Now, in patients who appear to get alpha-4 beta-7, they appear to do a lot worse compared to patients who did not get alpha-4 beta-7 from a cancer perspective. So the short answer is, I think if you have colitis, changing your diet is probably not going to be that beneficial. The immune suppression is going to be key. The immune suppression that is key, though, the steroids and a key consideration of which biologic. And again, this is probably something that the gastroenterologist needs to heavily involve the oncologist to co-manage. Somebody shouldn't be making a decision in isolation.
Is including a bland low fiber diet going to be detrimental to the efficacy of immunotherapy?
I think so the way you want to think about diet from an efficacy perspective is there's a certain amount that is permissive, right? So most of us would agree that just from a commonsensical perspective, that you probably need to be walking around 5 miles a day, right? Just help. US Preventative Task Force says that you should walk 5 miles a day. Actually, the exercise requirement is 45 minutes, 5 times a week. Turns out not a lot of people do that. And so much like that, from a fiber perspective, the recommendation is around 38 milligrams of fiber a day. Now, if you get colitis, is a low fiber state going to worsen the colitis or not? I don't think so. I think the problem with fiber and colitis is that the data that tells people that fiber and colitis is bad comes from inflammatory bowel disease. And checkpoint-related inflammatory colitis is not the same as IBD. Now, that's not to say that when you have an acute episode of colitis, if you go and take 60 grams of fiber, that's really good because you're going to be having diarrhea, and that's a little uncomfortable. But it's not necessarily going to worsen things, but it's not going to help you to recover from colitis. So certainly during that short period of time when you're recovering from colitis, you probably may need to alter your diet slightly, but the beneficial effect of fiber is over the long term. It's over the spectrum of getting and recovering from immunotherapy.
Thank you. I have another question from the Zoom. Should I have met with a nutritionist as soon as I was diagnosed? Is it too late to increase the microbiomes in my gut now that I am on immunotherapy?
No, it's never too late, right? I mean, it's like dealing with your wife's crazy cousin. It's never too late to be able to make your gut microbiome better. Again, the nutritional element is an important one too. One of the problems is that, we have an early intervention nutritionist from the concept of stem cell transplant and other cellular therapies, but we haven't quite done that in immunotherapy, and we probably should be doing a little better job of that. Certainly this talk last year, you heard from Katie Schmitz, who has said that you need to be moving in order to do better from immune therapy. So much like that, we think going forward that we need these multidisciplinary clinics where you see the cancer doctor, then you heard about how much you need to move, then you hear about how much you need to eat in order to get the maximal benefit of the treatments that you're already on in order to do better. But that is definitely something we need to think about incorporating a better job of doing. And we're not quite doing it yet, but we'd like to. And so we're certainly starting with the trials because we need to generate the data. But eventually we do see a setting in which you will meet with the exercise person, the dietary person, and your cancer doctor, and you're going to be getting a holistic idea of what you need to do in order to maximize your chances of doing better to immune therapy.
Thank you for your answer. It answered the question of the patient. Thank you.
One other question. This is also the same question. Can you please address the studies on the effect of peanuts and peanut butter on the spread of cancer?
Okay, so that is there are a couple of aspects to that. I think the answer to the question is going to be a very long one, so I think I'll keep it short. The problem with the peanut butter legume related issue is all tied up in a very unusual data set that needs to be further expounded upon. It's probably easier for me to answer that question by email because it's a very long question, because a lot of the data was generated in a very different setting and then has been looked at through a different lens. The short answer is that people think that some of these things may be, kind of like gluten, have individual effects that make people feel worse. Now, again, much like gluten, gluten is actually, from a historical perspective, is a very recent addition to our nutritional status. So humans have been around for hundreds of thousands of years. Gluten has been in our diet for about tens of thousands of years. We needed stonework in order to get gluten because until then we couldn't break down corn, we couldn't break down wheat. So it's a relatively recent addition to the sort of human spectrum. So much like peanuts, quite cultivation. So this appears to be a particular patient population related issue. And I think these are one of those things where you can't extrapolate beyond that particular patient population in which the data was generated. So I think it's probably better that person sends me an email. My email is actually available everywhere. You just Google my name, you'll find my email address. Unfortunately, you'll also find my phone number. So email, don't call. And I'll answer the question with some context.
Any other questions? Excellent.
Okay.
Thank you so much. So our last talk will be from Brittany Sanava, who will be discussing pediatric. The time is now for standard approaches to pediatric melanoma. Welcome, Brittany.
Hi, everyone. Thank you for having me. So I am a pediatric oncologist here at the University of Pittsburgh, and I am always honored and humbled to come here for the AIM Symposium every year. Many will first ask me if children get melanoma, and they do, of course, which is why I'm here. And I like to go after everyone else's talks because it's really important to think about, we've heard really fantastic talks from Dr. Najjar and Dr. Davar, and I benefit from all of the work they do. So in the rare chance that I do see a patient that has metastatic melanoma and they're young, the studies have been there, the treatments are available, but we need to take a few steps back. And that's what I hope to highlight today, because as it turns out, children are not little adults, and pediatric melanoma is not little melanoma. So. Hold on, I'm frozen. Oh, got it. I'm frozen. I just needed you to run up here. Thank you. Okay, so this is our overview for today. So first, just to give you a little bit of background about pediatric melanoma, how we classify it, and how we think about treatment. So as you all likely know, there's almost about 100,000 new cases per year of melanoma in the United States. And when we think about the numbers that impact our children, it's just a tiny fraction. So in the 0 to 20 age population, which is the population that I most frequently take care of, we see about 400 new cases of melanoma per year. And important to say that's reported clear melanoma. And I think what I hope to have you walk away from this today is that actually making that diagnosis is really challenging. And so knowing what to do with patients with melanocytic tumors is really challenging. Now, when we push up into our young adult population from 20 to 34 years of age, it starts becoming much more prevalent at about 5% of the overall cases. And then really for young patients, it's the second most common cancer in that age range. And just to also put into context, as a pediatric oncologist, the total number of all pediatric cancers per year in the United States is 15,000. So we see just a fraction of all comers of all different types of cancers, leukemia, melanoma, brain tumors, compared to the overall number of melanoma cases. And that really makes a difference in terms of how we study and how we get the numbers of patients to really make a significant difference, like my colleagues have in research. So unlike older adults where squamous cell, basal cell are far more common, this really is the most common cancer, skin cancer in children. So if we see skin cancer, it typically is melanoma. So how do we classify it? A lot has to do with the biologic behavior. So what is the chance that tumor on a child is going to spread, cause trouble, and need systemic therapy? And so when we think about young patients with melanoma, we usually classify it into three main categories. So one being conventional melanoma, so adult type melanoma. The second being melanoma arising in a congenital nevus. So we have some patients that are born with really large nevi that are covering large portions of their body. And that melanoma is different in how it behaves and how it arises. And then the last is a special category called Spitz or Spitzoid melanoma, which adults can get as well, but is far, far more common in children. And this is one of our most challenging subtypes. Despite these subgroups, we know that the behavior still differs from adult melanoma. And so if I have a child walk into my office and they have, conventional adult type melanoma, that doesn't really tell me which child is going to go on to have a more aggressive type of cancer and which child we could maybe back off from the treatment. And interestingly enough, we know that a child that comes in with the exact same stage of conventional melanoma as an adult will generally do better than that compared adult. But again, I don't know how to predict up front, like Dr. Najjar was speaking about, who that child is going to be. And even within the pediatric population, we know that our little kids, so our 0 to 10-year-old patients, they just do better with melanoma than our kids who are in the teen age. Again, we're not exactly sure why. And so this smaller subset of children whose tumors are going to behave like an adult melanoma are really difficult to predict. And you can imagine that these children have long lives to live, and putting them through really large surgeries and potentially toxic therapies can have significant implications if that's truly not needed. And then we get into the population of tumors that is what I see most commonly and is really, really challenging. So we see a lot of tumors that are biopsied, and we get the result that this is an atypical melanocytic neoplasm or tumor. They're typically in the Spitz category or something called MELTUMPS, which is a melanocytic tumor of uncertain malignant potential. And we've made a lot of headway over the past decade in terms of some predictive biomarkers within the tumor that we can say, okay, those tumors usually act more like adult melanoma, those tumors don't. But we're still really not sure about how to integrate those studies up front when a patient has a biopsy. And then likewise, in conventional melanoma, it is very clear that a sentinel lymph node biopsy and the status of your sentinel lymph node, it will appropriately stage you. We can predict your risk for recurrence, and even that does not have the same prognostic utility in these borderline melanocytic tumors. So with all of that, how do we treat our patients? There really is no separate well-defined management strategy for pediatric melanoma. And the surgical excision of melanoma remains the primary treatment modality. And like many patients in the room will know, the size of your excision of that primary tumor is dependent on how thick the tumor was or how deep it had grown into the dermis. Most melanomas are highly curable with surgery alone, which is great. And most of our melanomas that come in are in fact local at diagnosis and amenable to surgery. And so here we have really almost bread and butter for my adult colleagues, the National Comprehensive Cancer Network guidelines that give us evidence-based surgical recommendations for how much surgery needs to be done for a certain thickness tumor. So what does that wide local excision look like? Who should get a sentinel lymph node biopsy and who should get systemic therapy? And this is all supported by robust adult clinical trials, but not necessarily pediatric specific. So how did we arrive here? And I think, this is, it's almost, I don't know how much my adult colleagues even think about this now, but it's important to think about in the context of children. So how did we arrive at the current recommendations for surgical management of melanoma? And here, we won't go into great detail, but in general, based on the thickness of the tumor, the Breslow thickness, which is depicted below. So either you have a thin melanoma, T1A melanoma, or a really thick melanoma, T4 melanoma. That surgical management, how much skin you need to take off around that tumor is guided by how thick that tumor had grown. And then likewise, that thickness also predicts who will have a positive sentinel lymph node, and that guides your decision on who to do a sentinel lymph node. Again, these are adult recommendations. So what about, thinking of the surgical treatment? How did we arrive here? Well, years ago, prior to the discovery of how important it is, the staging of the primary tumor, that thickness, there was a huge amount of skin taken off. So large surgeries that could have a lot of significant consequences. Then, it became known that the thickness was really important, and the margins of that surgery were scaled back. And in 1980, there was the first prospective trial looking at surgical margins. So we've heard today about how important prospective clinical trials are. They give us the data that we know that guides our treatment of patients today. So this is not by any means to go into detail, but just looking through that there is a lot of historical background for how we treat melanoma. So from 1980 onward and ongoing currently today, there's been multiple trials looking at different amounts of surgical margins, the healthy skin that needs to be taken off around a localized melanoma, and how that impacted patients' OS or overall survival and DFS, disease-free survival. And now, you know, is exciting to see that we're in the current era, we're thinking more too about how this impacts patients. So how does it impact the quality of life, safety, et cetera? And that's something I think about a lot in my young patients. So there's a current clinical trial that's a multi-center trial that's ongoing and looking specifically at surgical margins, and it's currently recruiting patients. And so, you know, this picture here is to show you that that red dot is the tumor in the center. Whenever we say a difference between a 1 centimeter re-excision or a 2 centimeter re-excision, it actually equates to a really significant amount of extra skin that needs to be taken off, because that's the radius margin that's measured. And you can imagine that in a young patient who has far less surface area, they have to grow into that body, these surgeries can be really, can be very quite morbid. And so currently there's a trial looking at 1 centimeter versus 2 centimeter margins for primary lesion re-excision. Again, this is in adult patients, which is the problem we face in a lot of cases. It's thought that a reduction in margins is going to improve patients' quality of life. If you look at the inclusion and exclusion criteria for this trial, it's for patients 18 years of age and older. So the vast majority of my patients would not be eligible. And the patients that are excluded are the patients that I see. So those patients with uncertain diagnosis of melanoma, i.e. the so-called melanocytic lesion of unknown potential, are excluded. So we're left back to the drawing board with our young patients. So, you know, thinking of what we do in children, and here's you know, a picture to depict that these are large surgeries in young patients, or large surgeries in anyone. But if the larger they get, they can be associated with more complex surgeries. They can have issues with wound healing. They can get surgical site infections, be admitted to the hospital for these surgeries. All of the impact that living with that scar for the rest of their life may have on them. And of course, this can decrease overall quality of life. And so the goal is to really improve the care of our patients and the overall experience of our patients without compromising any of their oncology outcomes. And this is all just technically more challenging in our small patients. So when we think about the surgical management of a pediatric melanocytic tumor, there's genuine uncertainty. You know, it's really interesting. In my clinic, I see all patients before their surgery, because our surgeons feel so uncomfortable with making this judgment call on these young patients with melanocytic tumors. They know that they're big surgeries. They know that the margins are important, and there's data to support which margin we choose. But because we don't know exactly how that tumor is going to behave, if it's going to come back, if it's going to cause a problem, the surgeons don't want to do the surgery until they consult with an oncologist and we make a plan. So this, in my clinic, is one of the most difficult decisions that we make. So, you know, what's the surgery going to look like, and are we going to do a sentinel lymph node, and how are we going to interpret it when we get those results back? And so, you know, I'll leave you with an expert consensus statement that can be found that just really sums it up, that an excision margins are tailored to individual cases based on size and depth, and a sentinel lymph node biopsy is not recommended unless a malignant tumor cannot be ruled out, which again, we don't know how to do that yet. So very challenging. And so we really need prospective data and standard management recommendations for our patients. So how can we do this? And I'm going to take you through a little bit of information about our pediatric consortium called the Children's Oncology Group. So in the field of clinical trials in oncology. We have our National Cancer Institute, or our NCI, and through that, we have the National Clinical Trials Network, or NCTN. And these clinical trials are meant to improve the lives of people with cancer by establishing new standards of care and new treatments approaches. So what about in pediatric melanoma? Many patients that are listening to this today might have been on trials through ECOG or SWOG, our adult consortia. And here we are, COG is our pediatric consortia that you wouldn't know about if you didn't take care of kids with cancer. And this is a group that I am incredibly proud to be a part of. So this is the largest organization devoted exclusively to children and adolescent cancer research. It unites over 10,000 of us in over 200 leading children's hospitals and universities across North America, Australia, and New Zealand. More than 90% of kids diagnosed with cancer each year in the United States are cared for at Children's Oncology Group institution, which our institution is. And it really has turned children's cancer from what was virtually incurable 50 years ago to being that over 80% of children diagnosed with cancer will survive. And so this large multi-site structure of COG really allows the conduct of research for very rare childhood cancers, including melanoma. And I think we've learned from our previous talks that we really do need, we all need to come together to really make a difference in these clinical trials. So what has the Children's Oncology Group done for melanoma in the past? So importantly, there's been no prior COG-led melanoma initiative. So that's what we're here to change. In the past, we jumped on some of the ECOG and SWOG trials for kids 12 and older. And these were all trials that used interferon, which is no longer recommended and have been closed to accrual for many years now. And so, now we have over 33 FDA approved drugs for melanoma, not specific to pediatrics, of course. These have all been since the last COG participation in a trial. We know that surgery is still the most important, and so we use these as an adjunct to surgery. And the thought and the reason I'm giving you this history is that it is very hard to make a difference in the field of melanoma in terms of systemic drugs in children, because by the time we get the numbers to have enough data to make a true statistical difference, our adult colleagues probably have moved on to the next really amazing systemic therapy. And so what about looking at a multi-center trial, looking at the surgical management of these patients, because I hope I showed you that it is a really difficult decision to make. So our hypothesis is that a COG-led study of risk-based stratification of the primary surgical management of pediatric patients with atypical or malignant melanocytic tumors, again, because that distinction is really challenging, will be feasible, and it will inform our development and implementation of future larger prospective trials. So I won't get into the nitty gritty of this, but just to take you through, what we are attempting to do is that patients would be seen at a COG site. They might have an oncologist that's really never taken care of melanoma, but that's okay because we have a trial that's designed by people like myself that think about melanoma all the time. Those patients would be enrolled into the clinical trial. Experts in the field of looking at melanoma under the microscope in young children would review that biopsy. If they decided, this actually doesn't look like melanoma or anything atypical, those patients would be observed. If it did look like it was atypical or malignant, we would do more further molecular profiling on them. And the decision about how to decide high risk versus low risk is a topic for a different day, but a lot of work has gone into that. We would say, okay, we think your tumor is high risk. We think it's more likely to behave like a true adult melanoma. You go on to get the standard surgery that an adult would get. And then you patients that don't seem to have high risk tumors will just have a really tiny re-excision, no sentinel lymph node biopsy. And we will observe you to see, to ensure that you don't have a recurrence. And so because the COG has never done this, there's a lot of questions is this feasible? Can we get patients and providers to enroll their patients? How are we going to do this? And so I won't give you, I'll breeze through this next section, but I just think it's really exciting to see that maybe others are becoming as excited about melanoma as I am. And so we went out into the community of providers and said, you know, hey, we are here as a pediatric oncology group, we want to conduct a study looking, trying to centralize the care of these patients so that no child is left behind. And dermatologists and surgeons and pediatric oncologists, what do you think about this? How are you referring your patients? Can you tell us a little bit more? And would you be willing to send your patients to us so that we could work together to improve the care? And so, you know, we first asked our children's oncology group sites, you know, how many new patients with cancer per year do you see? And do you see patients with pigmented melanomas or atypical Spitz tumors? And the answer is yes, so the numbers are there, which was actually surprising to us. We had 70 institutions respond to our survey, and there's about 240 COG institutions, and of those 70, there was a total grand estimate of about 200 to 250 new patients per year being already referred into a children's oncology group site. We next said, well, what are the clinical scenarios prompting referral? Why are you seeing these patients? Why are you consulting with other medical specialties? And by and large, our pediatric surgeons, our pediatric dermatologists, our general dermatologists, and our pediatric oncologists all said that if they get a pathology report back after a skin biopsy that said that a child has melanoma, they're sending them into another subspecialty to help manage that. Likewise, if they're coming back with these atypical Spitz and non-Spitz tumors, which again are really challenging, they're sending them in. And then lastly, if they did a biopsy and there's still some tumor remaining or there's positive histologic margins, they're sending them in, and they're waving the white flag that they need some help from other providers that might know a little bit more about taking care of these patients. Then we asked them, are you interested in a prospective trial? Would you send your patients to us? If we had a trial, could we finally work together to take care of these patients? And the overwhelming majority said absolutely yes. So all of our providers that see these patients up front, the majority said yes. The second answer was maybe, and really very few said no. And when we looked at this data, most patients that said no, we wouldn't send patients, they were typically saying, I also don't take care of these patients, which of course makes sense. And so lastly, we said, okay, well, if you have a patient and you're consulting with another provider and you feel like you're lost, you don't know what to do, are you already thinking about talking to a pediatric oncologist? And most of our providers also said yes. So pediatric surgeons and pediatric dermatologists are typically the doctors and providers that are performing these biopsies of suspicious skin lesions in kids. They said, yes, absolutely. If I'm getting these back, I'm sending to a pediatric oncologist. And so, you know, conclusions here are that our respondents identify that melanoma and atypical melanocytic tumors are challenging and that they need to consult with other specialties. We figured out that there really is complex referral patterns, which I know we see all the time. They're in the hands of many different types of providers, but most of them are still wanting to consult with pediatric oncology in these settings. Patients or providers are interested in a prospective trial, resounding yes. The vast majority said absolutely, we would be interested, we would refer patients and we would collaborate. And the results of this multidisciplinary survey suggest that these patients are being referred to pediatric oncology. The interest in a trial is strong. You know, this really is an unmet need and perhaps can show that a trial of this nature, which would be a big undertaking, is feasible. And then last, I'll leave you with, you know, we're here, we think we can do this. I just actually 2 days ago got back from our Children's Oncology Group National meeting where I proposed this, and it was well received. And so we're going to move forward with trying to get this through. But in the design of this, one of the things that I like to bring up is, you know, patient advocacy is truly essential. So Our high-quality clinical care requires our patients to provide information about how they're feeling, their symptoms, and any effects of our prescribed treatment. So in this, it would be, and being on a clinical trial, and the prescribed treatment would be their surgery. I mean, how does this impact their life? We know patient-reported outcomes, or we call them PROs, whenever they are embedded into our COG trials. Foundation support, such as AIM, is critically important, and the voice of the patients and families is critically important upfront in the trial design. And so we really do want to hear the impact of diagnosis and treatment from our patients and their families. And with that, I will thank you. Thanks to all of our groups at the COG that have been working hard to put this together. I hope next year when I'm standing up here, I can tell you that it's a good go, and that we're going to be recruiting our first patients. And of course, thank you to all of our patients and families that make this possible.
So Brittany's talk is open to questions. I must say it's a thrill to be working with Brittany, who's been working on telomerase, who's been working in the training program and is now leading the program at Children's and making things happen. And her message is that for pediatric melanoma, as for adult melanoma, interdisciplinary, multidisciplinary care is the standard. I think that's, please. Oh, she's pressing her head. Okay.
Thank you.
Excellent. Thank you so much. Good. Well, we are smack on target. The time is 11:20, and I want to thank all of our patients and caregivers who come in, all who are online. I know more than 110. To our speakers who've really devoted Saturday morning, St. Patty's Day, to come in and speak. And most of all, to thank my administrative assistant, Lisa Huntley, without whom none of this would happen each year. And finally, our sponsors, Bristol Myers, Iovance, Merck, Natera, Novartis, and Pfizer, because everything we've done in AIM from the very beginning, 20 years ago when I worked with Val to found this in, amazingly, 2004 at ASCO, New Orleans. It's been a union of industry and academia. It's a union of patients and caregivers. It even has included, believe it or not, the FDA on a bunch of our meetings, because the whole purpose is to get new agents through the pipeline. And so we're thrilled that really for whatever it is, since 2011, this tumor has been the pathbreaker, bringing new agents into play. And there's no end in sight in the cornucopia that has opened up for us. So with that, I'm going to say thanks to everyone and turn it to Anne for the final comments from me.
Thank you. Thank you, Dr. Kirkwood, and of course to all of our panelists and to everyone who's joined us today. And I thank you for 5 more minutes of your time to talk about AIM at melanoma. As we often hear at the beginning of these panelist presentations, they'll talk about their disclosures. And my disclosure to you is that I am very proud to work for AIM at melanoma. And I'd like to know, for you to know a little bit about what we're doing to support people who are living with melanoma. So if I can figure out how to make this work, I did it. What I want to do is draw you to our website. Everything that we offer is available at no cost. We want to make sure that the information on our website is relevant, that it is up to date and accurate. We don't want you to go shopping for information. Please come to AIM at Melanoma. Probably our most visited websites have to do with staging and relevant treatment. Another area of our website that is frequently visited has to do with clinical trials. People want to know, what are they? What do they want to accomplish? If I decided to be a part of them, what would that look like for me? So we have a wonderful section, brand new section on clinical trials. We are very fortunate that Melissa Wilson, who was not able to join us today, who's the senior PA here at UPMC, she is also part of AIM, and she runs a service called Talk to a Medical Expert. So those individuals who are struggling to understand some aspect of their care can fill out a form, and she will do her best to make you understand the plan that your care team has for you. She's also developed a webinar series called From the Clinic to the Living Room, where she's taken many of the questions that people come to with her, and she's made, some people are more auditory learners, and so she's made webinars out of those and interviewed some of the top experts in the field. Of course, we have these symposiums. AIM at Melanoma co-hosts 10 a year. What we will do at the end of today's symposium is we will take each one of the presentations, we will edit them and divide them by topic and put them back onto our website so that they could be viewed again and again and again by the public, and they certainly are. In addition, we have a podcast I want you to know about. Having, cancer is an emotional experience, and Dr. Ray Liu is our podcast moderator. He interviews people about things like, what do I do now that I have a new relationship with the son? Or how do I build a care, team around me of people that love me? How do I, communicate to them what it is that I need while I'm going through my cancer journey? So I invite you to come to our website and visit some of those podcasts and see if you will benefit from them. We have a lot of survivor stories. We hear again and again that people who are newly diagnosed need inspiration that comes from hearing the stories of survivors. And another way to be inspired is to join our peer-to-peer support group. We have 50 volunteers from across the country who have all completed treatment and gone through a mentorship training program, who offer an empathetic ear, that one-on-one experience, that true understanding that comes from having already walked ahead of you, inspiration and hope. And so if you're at the beginning of your melanoma journey and you would like someone to bring into your circle of trust, please reach out to AIM and we'll connect you with somebody. I connected 2 people just yesterday. And then also, I want to say that one of the most important things we do, of course, is to continually seek a cure. And that comes largely through funding our tissue banks. We've talked a lot about how important tissue is and how important it is to the future of a cure. And UPMC, in one of the many, many ways that they support this, AIM at Melanoma, is that they have a Steps Against Melanoma walk that they run, and it is Saturday, May the 11th. We invite you to come to be a part of this effort to raise awareness about melanoma, to raise awareness about our tissue banks and their importance. So if you would like to join us, please go onto our website and get more information about that walk. And then lastly, I just want to say that I'm here for you in my role as the Director of Community Engagement. I'm often the person that gets those first inquiries and gets them where they need to go. I'm so happy for you to reach out at any time, and I'll try to direct you and get you the direction you need to go. And with that, I'll just say once again, thank you so much to UPMC, to Dr. Kirkwood, to Lisa, who's amazing, and to all of our panelists. And thank you for coming, and we hope to see you again next year.